Next slide. I'd like to welcome everyone to our Suicide Youth Prevention Summit. And I want to thank everyone for attending. This event is made possible by a grant from the American Academy of Pediatrics and the American Foundation for Suicide Prevention. And a special thank you to the Alameda and Contra Costa Medical Association for partnering with us for the promotion of this event. Next slide. I want to thank our planning committee and staff for putting this event together. Dr. Erica Berman, Danica O'Leary, especially Sana and Yolanda, and Ezrathi. Next slide. You have sent to you the syllabus for which has copies of all of the slides from our speakers. But we have a very ambitious agenda with covering a lot of information between 8 and 12. So we're going to try to keep onto the schedule as closely as we can. Next slide. A few things about our logistics. We're glad you're here to share this important topic with us, and we want to hear your questions and comments. So please put them in the chat. And we have two times for question and answer sections of the summit where we can have some discussion about things that you would like to comment or questions you would like to raise. During the summit, please keep your microphone off and your video on so that we can make sure that you're receiving the information that we are hoping to provide. We are approved for 3.5 hours of CME, but in order to receive the CME for the event, you have to complete the post-summit survey that you'll receive right after the event. Also, we are able to provide you with some free materials to have for your office or to distribute. And so one of the questions on the post-summit survey will be to tell us if you want this free information and what address you want us to send it to. If you have any technical problems, please email Sana at Project Coordinator. Next slide. Our first speaker this morning is Lisa Morgan. Lisa is the founder of the Lisa Morgan Consulting firm and a certified autism specialist, and she co-chairs the Autism and Suicide Committee for the American Association of Suicidology. She is a trauma-informed consultant specializing in crisis support and suicide prevention for autistic individuals. She's going to be talking to us about autism and suicide prevention for autistic youth. So take it away, Lisa Morgan.
Thank you. I'm going to share my slide. So welcome, everyone. I'm going to be talking about autism and suicide prevention for autistic youth. Here is my disclosure. And my learning objectives for today are going to be, I'm going to be describing lived experience on both attempts and loss. I'm going to be discussing autism culture and how that plays into suicide prevention, and explain some autism-specific resources that were developed by the Autism and Suicide Prevention Work Group. So I just want to make a note that many autistic people prefer identity-first language because they identify as autistic people. They don't view themselves as being on the spectrum or with autism. Autism is part of who they are as a person, and as an autistic adult, I prefer identity-first language, and I recognize that not all autistic people use or prefer this language, and that each person should be given the opportunity to choose the language that they prefer. So, like I said, I'm going to be talking about my lived experience with suicide, attempt, and loss. So, I made an attempt in December of 2014. And leading up to my attempt, I didn't realize I was suicidal. And from supporting autistic people in crisis for the last 7 years, I've realized that it's an experience of many other autistic people across the lifespan as well. And reaching out for help hurt, actually. My experience is also the experience of many other autistic people because suicide is a leading cause of premature death in the autism community. The suicide rate is up to 7 times higher than the general population, and that's across the lifespan. A study done at Kennedy Krieger Institute last year found that 71.5% of the autistic children in the study, some as young as 8 years old or younger, were experiencing suicidal ideation where they had thought about dying or expressed, not wanting to live. And then as many as 18.1% of the autistic children in the study even had plans to die by suicide. So when I was struggling with suicidal thoughts, I didn't realize I was suicidal. I knew I was extremely overwhelmed and having trouble coping, having trouble sleeping. I was very easily dysregulated, and my coping skills were not as effective as they usually were. But I didn't connect all of that to being suicidal. Even thoughts of escaping, some including dying, I didn't interpret as myself being suicidal until I actually attempted. And my attempt was driven by overwhelm coupled with impulsivity. And impulsivity is a dangerous aspect of an autistic person's thought process when they are overwhelmed and experiencing suicidal ideation, whether they realize it or not. And then 3 months later, my nephew, suspected autistic, died by suicide. There are unique risk factors of suicide for autistic people, including social communication difficulties, unmet support needs, being diagnosed later in life, which is actually considered a diagnosis after the age of 18, autism burnout, which can be significant and debilitating, thwarted belonging and perceived burdensomeness. And those are just to name a few that are the most supported and researched. And also all the suicide risk factors of the general population pertain to autistic people as well. And then 3 months after that, my husband of 30 years died by suicide. One other unique risk factor of suicide is a co-occurring psychiatric diagnosis. So the night I found my husband, the first responders, the victim's advocate, the sergeant, and the neighbors were all kind and there to support me. But I did not feel supported because I didn't recognize their behaviors as support. The first responders told me where to stand so that I be safe while they went inside the house to do the wellness check on my husband. But they didn't know that my acute sense of smell, that I realized standing there alone, that my husband was dead just a few feet away from me on the other side of the garage doors and had been for several days. They didn't know they moved too fast when they surrounded me to keep me from going into the house after telling me what I already knew. And then a police officer put his hand on my shoulder heavily, which was alarming to me because I wasn't expecting it. I didn't know what it was there for. I didn't know how to respond. My anxiety was already really high. I felt that hand on my shoulder for months afterwards when I thought about that night. And it took a few years for me to realize that it was actually an encouraging gesture. The sergeant didn't know that he talked too fast, that my processing speed was slow due to my high anxiety, and I was nervous he was going to think I was lying. The neighbors asked me to eat dinner with them, not understanding that I could not do anything that resembled normal or make small talk at that time. And everyone was being kind and supportive, yet when I got the keys to my house back and everyone left, I was profoundly alone and unsupported. which I've called unintentional harm by well-meaning people. In my work regarding autism and suicide, I've heard stories of many autistic people who have gone to the ER stating they were going to kill themselves and were sent home because either the clinicians there found out the person was autistic and didn't think autistic people kill themselves, or the autistic person's presentation was such that they didn't act or behave or present as in crisis. And in that case, the clinician didn't understand how, for an autistic person, everything can be happening internally and they can look completely calm and fine on the outside. So that's an important piece of knowledge in supporting autistic people across the lifespan, is that it can, everything can be happening on the inside where you don't look like you're in distress at all. Many first responders are not trained in how to support an autistic person in crisis, just like I had explained the night that I found my husband. The behavior of autistic people can also be reacted to in a negative way and cause unintentional harm. So stimming can look like an autistic person may be using substances, or echolalia may look like an autistic person is not listening. The blatant honesty of autistic people can come across as rude. Not making eye contact can look like the autistic person is lying. So the reactions of supportive professionals who do not understand autism can cause unintentional harm because the autistic person is just being autistic, not any of the nefarious things I just listed. But ultimately, all this means is autistic people do not get their needs met. So what does unintentional harm look like? It's friendly and encouraging, even empathetic and caring, but to non-autistic people. Autistic people just need a different kind of support. So how do we begin to address these differences? One way is to consider that autism has its own culture. If you take nothing from this presentation with you today, please take this, that understanding autism and the culture of autistic people, so autistic people do not have to mask their autism, is suicide prevention. So indeed, culture is often viewed as a particular way of life or a specific set of people. It comprises its own beliefs, institutions, etiquette, mores, and norms apart from mainstream society. So while it's said that when you've met one autistic person, you've met one autistic person by Dr. Stephen Shore, there are similarities in autism that are unique to its members. Thus, there's a movement afoot to recognize autism as its own culture, which will go really far in supporting autistic people in the way that they can understand as support. So things you can count on in the autistic population is autistic people tend to have focused passions, and that can be used to help reduce some of the negative rumination and switch it to a more positive thoughts, because that rumination can be very, very heavy. And they adhere to routines, they communicate differently. Small talk is just not helpful. They speak and listen literally, and sometimes communicate without words at all, but they're still communicating in the way that they can, whether it's an assistive device. Sometimes in crisis, autistic people can't lose their ability to communicate when they can verbally communicate and normally. So emojis, text, drawing, anything to help them communicate their needs is supportive and helpful. So being accepted, normalizing behaviors, language and sensory experiences. So autistic people don't have to mask in mainstream society, which is research has shown to be detrimental to their a negative effect on their mental health. It's a great cost physically, mentally, emotionally, knowing that if they weren't masking, they most likely would be rejected or ostracized or just not included, which leads into thwarted belonging and perceived burdensomeness. Being able to enjoy stimming without judgment, wearing what's comfortable, which could be the same kind of clothes every single day. So when autistic people get together, they don't have the same kind of, they can be themselves more. And that has shown to be very helpful in feeling connected, which is a big part of suicide prevention as well. Withdrawing for self-care too. It's also a warning sign of suicide. So, allowing autistic people to have that chance to withdraw for self-care, knowing that they're not being avoidant or anything, and trying to determine also whether it is a warning sign of suicide is supportive. And so the Autism Suicide Prevention Work Group, over the several years since I founded the group, we have developed these resources. And we have some more coming as well. The first one is, it was originally to help crisis center workers in identifying autistic people who may not disclose their diagnosis of autism, and also supporting them in a way that they could feel supported. It is now it's now translated into Portuguese to be used in Portugal and Brazil, and Spanish, and it's being translated into Danish as well. It really helps to know how to communicate with autistic people. It covers asking direct questions, allowing extra time for processing, helping to shift those negative ruminating thoughts, language to avoid, speaking logic words instead of emotional, using positive coping skills and actually explaining them, because a lot of autistic people have never, reached out for support before. So they may not understand what they're being told is actually a positive coping skill, and to facilitate a safety plan. And then we have the warning signs of suicide for autistic people. The purpose of this resource was to present warning signs of suicide for autistic people specifically. And what it does is it really watches for changes from baseline as far as withdrawal, regulating, self-harm, or depression. It covers not acting like non-autistic people may act in a crisis, not being able to verbalize emotions. There's a new focus on one about having a new focus on death-related topics, and having to discern whether that's a special interest or if they're suicidal. May research ways to die by suicide. And so there's 10 in all. And it's really, it comes with scenarios so you can understand what it looks like in real life, and it has research. The next resource that we have is called Reasons for Living, where it's designed to develop a list of reasons for living, which helped me after my suicide attempt. Somebody did this for me, and I really use that a lot, because a lot of times when you're experiencing this suicidal ideation that gets too heavy and too much to manage, you're usually alone. Sometimes you're alone, or you may not know how to reach out, because reaching out is that social, has that social aspect to it. So having this list of reasons for living can remind somebody why to not die. It can help give them hope, help regulate their feelings as they look at this list of things that they love to do or just love having in their life. Remind them that they have a purpose too, because masking can cause a person to have an underdeveloped sense of self. And so reminding them of their purpose as well is included in this resource. And then the last one that we have is 988 information for autistic people, because many autistic people, teens, young people, old people, they have called 988 and it has not been supportive for them. I had that happen to me too. I just had suicidal ideation where I could not manage it, so I needed to reach out for help, and I did with 988. And granted, you don't know who you're getting, but I did disclose my diagnosis of autism, and the words were just too much for me at the time. My processing speed was slow. My anxiety was very high. I had high suicidal ideation. And I asked if we could sit in silence for a bit. I just really needed to be connected to another person, even if we sat in silence. And what I was told was, we can't sit in silence all night, which confused me because I didn't ask for it to be all night. And I don't know how that happened. And when I asked about that, the person on the other end told me I was being combative, and he ended the call, which then just makes autistic people feel more alone than they did before they reached out for 988. So what this does is it um, sets expectations for the use of 988, what it's for. It helps autistic people to have an idea of what they are looking for before they text, chat, or call 988. It gives them ideas of what they can reach out to for support for. Um, gives them an opportunity to provide feedback, because there is a way to do that. And so this resource has just been released in the last year, and I just covered all of that. So in conclusion, we all have a role to play in suicide prevention efforts, to learn directly from autistic people with lived experience. And don't be afraid to ask about suicidal thoughts, because sometimes with autistic people, they're looking for that opportunity because they don't know how to start that conversation. And then listen to the answer in a way that they will return and talk it again. Remember that autistic distress does not look like neurotypical distress many of the times. Um, make use of the resources, and then help by advocating for more autism specific training for crisis center workers, emergency department clinicians, and other mental health professionals. And questions will be asked in another time, but if you want the resources, they can be found at this website. And thank you very much for listening to me today.
Thank you so much, Lisa. That was really, really an important way to start our conference. And thank you so much for sharing your personal information, because I think it makes it more real for everyone to know that all these pointers that you have developed and advocated for are based on a lot of experience that you've had, both personally and with working with other individuals on the with autism or on the spectrum, or however you want to call it. So thank you so much. Really appreciate it.
Thank
Next,
you.
next slide, Sana.
One second.
Okay, so the next thing we're going to be doing is talking about screening as part of youth suicide prevention. Next slide. And the objectives is to really understand the importance of suicide screening, to be aware of the tools that are available, and to know that suicide screening does not increase the frequency of suicide thoughts in youth. Next slide. So first, to clarify the terminology, um, when we're talking about suicide, we're using that term to mean death that's caused by self-directed injurious behavior with an intent to die. And as we know, there are many individuals who have what's called non-suicidal self-injurious behavior, where you're deliberately injuring yourself, but you don't have suicidal intent. So those are really two things that are separate. A suicide attempt is an explicit intention to die as a result of self-directed injurious behavior. And mostly what we're going to focus on today is suicidal ideation, which is thinking or planning about a suicide, which reflects a desire to die. And what we want to do is to provide prevention so that we don't see a suicide attempt or a suicide death. Next slide. So why is this a topic that we're spending our morning on? Well, really, suicide is the second leading cause of death in adolescence. This is a big deal. Um, and what we want to do is to save lives by thinking in a preventative way about what we can do to reduce it from being the second leading cause of death. And we have three goals in that. One is preventing a crisis. The next is responding to a crisis. And the last, which we'll talk about somewhat, is crisis stabilization. So, just to give you an idea of how big an issue this is, in 2020, the Suicide Prevention Lifeline nationally received 2.4 million calls in 1 year. And in that year, over 300,000 of them were from California. And in July of 2022, California joined the 988 Suicide Prevention Lifeline. And since that time, so originally it was just a phone number. Now it has the ability for people to call, text, or chat. So since July of 2022, they have had 14 million contacts, including 9 million calls, 2 million texts, and 2 million chats. Just so that you know, the answer rates currently are 92%. Um, and in February 2025, I found data about how it takes the average time to answer a call is 34 seconds, and the average call length is almost 14 minutes. So we're talking about something that is providing a lot of support and is really available uh, both by call, text, and chat. So I'd like to propose that we really need to be performing universal screening um, of uh, of the children that are in our care. And why? Okay, so first I said this is a common problem. The second reason is because most young people keep suicidal thoughts to themselves and may not bring up the topic on their own if they're not asked a direct question. We know that universal screening is a more comprehensive strategy than targeted screening, where the provider decides that, well, this is a potential mental health problem, and so we're only going to screen individuals who are presenting with behavioral health issues. While we do know that patients who present with a behavioral health concern are at higher risk for suicide, patients presenting with other health concerns, or even those who are simply engaging with the medical system for preventive care, can actually have pressing mental health concerns that they're not talking about with anyone. And that can be both in autistic people, but also in neurotypical people. Next slide. So, really, universal screening is an important way to help all patients feel less alone with suicidal thoughts. Otherwise, they might pass through the healthcare setting undetected. They didn't bring it up, we didn't ask, and so it never came up. We do know from research that most people who die by suicide have visited a healthcare provider in the weeks or months before their death. Asking about suicide risk can really be a way to recognize someone who is at risk and to get them help. That's the whole purpose. So, universal screening helps to promote equity and address bias in care delivery, ensuring that all youth is screened across all demographic groups, communities, and care settings. Next slide. Why are we seeing such an increased risk for suicide in adolescents? Well, I'm just listing a few of the reasons, but clearly social media consumption is thought to be a, a risk factor. We do know that there's increased bullying and especially cyberbullying that can lead to increased suicide risk. We also know that family rejection of LGBTQ youth can be a significant risk factor, and we're going to be talking more about that, just like we're going to be talking more about anxiety and depression in neurodiverse youth. One thing that's often not recognized is a history of physical or sexual abuse that can become more and more salient to the adolescent as they start going through puberty. We know that history of adoption can increase suicide risk, and in occasional situations, we have potential glamorization of suicide in the media that leads to sometimes a series of suicide attempts. Next slide. Um, I put this slide up only because I wanted to show you how important this is. We have national data from 2023 that not only shows transgender and questioning students in grades 9 to 12 having a 25% uh, self-report of suicide attempts, but also close to a similar 24% in cisgender females and 12% in cisgender males. So we're talking about something that is not rare in our youth, adolescent youth. In addition, while we do have um, uh, increased across the board in suicidal thinking and some suicidal attempts. Actually, um, uh, suicidal attempts that require medical treatment is way disproportionate in transgender and questioning high school students than it is in cisgender male and female youth. Next slide. So, the Academy of Pediatrics has recommended that for youth ages 12 and up, that we have universal screening when they come for their preventative care visits or other healthcare visits. And for youth ages 8 to 11, screen when clinically indicated. The Academy does not indicate universal screening for children under age 8, but if there are warning signs, you should think about it because we are now learning that even children under the age of 8 have may have suicidal ideation and warning signs. What are these warning signs? Next slide. Well, one would be obviously talking about wanting to die or wanting to kill oneself. Actions such as putting grabbing their throat in a choking motion or putting the hands in the shape of a gun pointed to their head, uh, engaging in self-harming behavior, giving away their treasured toy and possessions, or acting with impulsive aggression. These are all signs that we really need to dig further into what's going on with the child. Next slide. So, what's available to us to be able to do this universal screening? Well, we have uh, well-validated screening tools such as the Ask Suicide Screening Questions. We have other publicly available tools. Next slide. So the ASQ is probably the simplest one, and it is well validated. It really consists of 4 questions that the healthcare provider asks the patient. In the past few weeks, have you wished you were dead? Yes or no? Past few weeks, have you felt your family or you would be better off if you were dead, etc., etc.? Have you ever tried to kill yourself? And if the person says yes, then to any of these questions, you then ask, are you having thoughts of killing yourself right now? And this takes very short amount of time. The answers yes, no don't require a lot of elaboration, but it gives the provider the opportunity to then pursue or to say, well, this seems like it's not a concern right now, but you should be aware that I'm here for you if these things come up, being open to discussing this. So just to show you that this really works, that these measures have been studied and show both concurrent validity and predictive validity. Um, the ASQ was first developed and validated for a sample of youth ages 10 to 21 presenting to the emergency room. and it had a sensitivity of 96% and a specificity of 87%. Using an outpatient specialty care study, the sensitivity was 100%, the specificity was 91%, and in outpatient primary care, almost the same numbers. So this has been well studied to show that it is a good way of picking up um, uh, children who are considering suicide, have tried, to, have made suicidal attempts, and um, and it opens the door to the conversation with your patient. Next slide. We also know that it has adequate predictive validity. So, for example, in a study that looked at uh, using the ASQ and then seeing whether there was, in fact, a suicide-related emergency department visit or death within 3 months after the screening, it showed a sensitivity of 60% and a specificity of 92%. And other studies have been similar. Uh, and so obviously things change over 3 months from the time that one did the screening. But if an individual is screened positive, then they definitely are at more risk for suicide visits to the emergency room or actual suicide completion. Next slide. What about screening for depression? Is that enough? Well, a lot of pediatricians and other healthcare providers use the PHQ-9A um, to screen for depression and then consider that that's enough to screen for suicide risk. But there was a recent study that looked at um, that 600 medical inpatients with a mean age of 15 years who completed both the PHQ-A and the ASQ and another suicide ideation questionnaire. And basically, what they found was that depression screening alone failed to detect nearly a third of the youth at suicide risk, and that 32% screened negative for depression, but were at risk for suicide on the ASQ. Next slide. One of the things that people worry about is whether it's safe to ask youth if they are having thoughts of suicide. And there, in fact, have been multiple research studies that have established that it is safe to ask young people about suicide. For example, a sample of young people ages 13 and up asking about suicide did not significantly impact the stress levels immediately or 2 days later. Other studies have found no longitudinal changes in suicidal ideation that are associated with assessing for suicide risk. So it is a myth that asking youth about suicide will, quote, put the idea into their heads. If it's in their heads already, we need to know it. What are the common barriers to screening? A recent study that was published in 2024 noted that most primary care pediatricians who were queried in St. Louis agreed with the AAP screening recommendations that I recently went over, but they expressed hesitancy due to the time allotted to their visits, their training, inadequate resources for follow-up care of at-risk patients. But when the researchers asked whether they thought that the recommendations were right, they said, yes, we agree with the recommendations, and we want additional training and support with quality improvement activities and support uh, uh, im to implement practice change. Next slide. So I'd like to spend the last few minutes talking about responding to a positive screen. Um, because one of the things that were mentioned by the pediatricians in that study, but also in talking to my colleagues, is what do I do if I have a positive screen? And so the first key is to interview the youth alone, to ask the questions in an ASQ. And if you have a positive, you need to determine the severity, frequency, and actual intent of any suicidal behaviors and thoughts. And you can use, there are a few other tools that you can use, such as the Columbia Suicide Severity Rating Scale or the Suicide Assessment of Five-Step Evaluation and Triage, or the SAFE-T, which is in your handout. You should do a medical assessment to look for any signs of self-injury on physical exam or abuse, or any other medical disorders or drug use. And then you should do a mental status assessment to determine the youth's mood, affect, level of relatedness and engagement, and the presence of cognitive, perceptual, or other thought disorders. Next slide. And then you need to develop a treatment and safety plan. And that the key to this is a plan to assess suicide risk level and protective factors. And this should be a collaborative process between the provider, the patient, and the family. There are a number of patient safety templates in your handout. And the key elements of all of these are looking for warning signs of increasing risk severity, coping strategies that the patient can use, stressors to avoid or manage, people and resources for help, and the steps to make the environment safe. Next slide. Um, Preventing a crisis, we want to have resources. And so, what they are now calling a digital apothecary, and you're going to hear more about Never a Bother, Saluna, CalHope, CalMap. And then we have many community-based behavioral health services, including school-based and school-linked resources, integrated behavioral health services, community-based behavioral health therapy, peer support programs, community health workers, and social determinants of health supports, such as social workers. So, developing a comprehensive plan is important. Next slide. Uh, Briefly, you're going to hear more about the hotlines 988 and 911, but be aware that they do operate 24/7, 365 days a week. They answer the calls and provide all these different options. They are staffed with clinicians overseeing clinical triage, and then the mobile crisis services that you will also hear about that are also operate uh, optimally 24/7, 365, although not in all of the counties in California. They are staffed by multidisciplinary teams who have had training and meet the patient where they are in the community and are overseen by credentialed and licensed clinicians. Next slide. So the key points about screening youth for suicide prevention is that it's important. It's the second leading cause of death in adolescence. 13% of all pediatric emergency room visits are for mental health issues, and 4.2% are for suicide-related issues. Pediatric providers need to be prepared to assist children and youth and their families with suicidal ideation, self-harm, and suicide risk. The Academy of Pediatrics has called for universal suicide risk screening for youth ages 12 and above using a validated suicide risk screening tool no less than annually. Pediatric providers, we now know, won't implement suicide risk screening unless they have a plan in place for responding to positive screens. And if you have a positive screen, what you need to do is a brief suicide risk assessment and develop a treatment plan, including safety planning. Next slide. Thank you for your attention, and I'm going to pass um, the, uh, the next to the next speaker, who is Peggy Rajsky, who's going to be talking about supporting LGBTQ plus youth um, with suicide risk data and resources for pediatricians. Peggy is a special advisor to the CEO at the Trevor Project, um, a philanthropic leader, an Oscar-winning filmmaker and entrepreneur, and an activist. She has directed Trevor, which is a short film about a teen facing suicide after being outed, and won an Academy Award, um, which won an Academy Award, and led her to start the Trevor Project in 1998. And she is now leading an LGBTQ plus youth crisis intervention and suicide prevention organization, so that is the Trevor Project is, in the U.S. and Mexico, and she has served on its board since its inception. Um, Peggy, we'd love to hear what you have to say about helping uh, prevent suicide in LGBTQ plus youth.
Thank you so much for that introduction, Dr. Renee, and I'm very happy and honored to be here today with everyone. And one of the things I have to say first off is, I think that talking about suicide is really, for folks who haven't had to do it much or for a living, really sort of shocking, surprising, and nerve-wracking. And I have to say that that's part of why I'm here today, is because I was in that position 30 years ago. And as Dr. Renee pointed out, I started out as a filmmaker. That's my background, my professional career. And I had been doing that for a couple of decades when I happened, a chance encounter with someone sent me off to go see a little one-man show down in the Village when I was living in New York. And it was a piece, a 5-minute sketch that was all about a young boy, a 13-year-old boy who's innocent, musical theater loving, loves his Diana Ross. And remember, this was back, post 80s. And anyway, just overnight, his world changes and word spreads he's gay, and he's immediately ostracized. And he, for the life of him, cannot figure out what happened. He was the same person one day, and the next, no one wants to have anything to do with him. And in that moment, he decides it might just be better if he checked out for everybody, for all involved. And he proceeds to go about doing some of the things that's been described here, giving away possessions, making a plan, and actually making an attempt on his life. Now, luckily, that child did not succeed. But one of the things that I did learn in the course of making that film is that gay and questioning youth are 3 to 4 times as likely to make an attempt on their life as their straight peers. And as Dr. Renee just shared, transgender youth have a rate that goes up to nearly 10 times as much. The other thing that increases your risk is if you come from an unsupportive family, and that will also escalate risk to almost 10%. Yet the good news is one accepting adult in a young person's life can reduce that risk by about a third. So this is part of why I'm here to share information for you about the truly critical role you all play. Now, like me, I imagine none of you expected when you started your professional lives as doctors and pediatricians that you might be asked to begin to explore more behavioral health issues, mental health issues. But as you know, your commitment to your field is about helping save lives. And this and the times and circumstances now require that. So while unexpected, it is a call that's being given to you. And on behalf of all the young people our organization serves, I want to thank you for taking the time, care, and interest to perhaps learn a little bit more about what you can do. So let me just pop up my screen to share a few things here. I have got our presentation here to share with you, and we are, just give me my moment as I go into my our presenter view. So has all that come up for everybody? Sana, am I on the right page?
We can see your notes.
Oh, well, we don't want that, so let me take that down. I apologize, folks. I have had my sharing tool just went off ever so slightly. But one of the things I'll do is, if you can give me 1 second, I apologize. I'll tell you what I'm going to do. Sana, if you would be so good, are you able? I'm going to do this one more time.
Go ahead.
All right, great. Thank you so much. And do you have it up, Sana?
Oh, Yolanda can share the slides.
Thank
Do you
you.
want to try one more time, Peggy, or do you want us to just share?
All right, I'll try one more time. Bless you.
Technology is wonderful until it isn't.
Yeah.
Well, you know, here we go. Okay. It says it's sharing on my side. Is it up?
Yes, we can see your slides.
Wonderful. Thank you
But
so much.
now we can see your presenter notes. It's okay. We can try to share on our end.
No. Here, we'll try this. I am going to just try to be able to talk you through. All right, folks. So here's the deal. Here's what the story is. And Yolanda, if you can get yours up, that would be great. Here's one of the most important things I want to share with you is that LGBTQ plus young people are not inherently prone to higher suicide risk because of their sexual orientation or their gender identity. Now, what does happen though is that, next please. What does happen though is that these young people are placed at higher risk because of how they're mistreated and stigmatized in society. And one of the things that we're seeing more and more is that in the land of adolescence, it's sort of terra incognita. What the stressors that they face, that those of us of a certain age did not grow up with ourselves, can be baffling and confusing, but it is those stressors that are putting all of them at higher risk, and why, in fact, we're seeing that suicide is one of the leading causes of death for this young group. One of the things that the Trevor Project did, and why I started it back in 1998, is that little film I made actually went on to be on HBO. And at that point, we were lucky enough to get Ellen DeGeneres to appear on as the host for that show. And I knew that there would be, given her the fact that in 98 is the year that Ellen first came out, we knew that there would be a lot of press and attention, and realized that there might be a whole lot of young people watching who would feel like Trevor, and that they might be like our character in a place that was not good, and that they might need a place to call. And when I realized that, I went, well, there just must be a number out there, and checked and found out that there were, in fact, lots of suicide hotlines around the country, but there was no standardized training protocol in place. So my biggest fear was that some young person would call a place and not receive the welcome they deserved, and in fact might be cut off in a very critical moment. So what do? We set up this 800 line, and because there was nothing like it in the country that could provide 24/7 specialized support. And that's what Trevor's been doing now for nearly 30 years. And one of the things that's so great about the organization is I've witnessed it grow from a one-person operation around my dining room table into a nearly 500-person support space devoted to supporting and protecting the mental health needs of LGBTQ young people. One of the things that Trevor does is, besides 24/7 crisis intervention via text, chat, and phone, is that it also has an incredible research arm that is publishing regularly updates about the mental health state and needs of this very large at-risk group. So, Yolanda, have you been able to put that up?
Yes, it is. I am sharing my screen. On the
Thank you so
results.
much. I appreciate that. So as you can see, one of the things that I want to let you know about our survey is that can you go to the next slide? Is that it was done and culled from a very large sample size, one of the largest that's ever been used of this group. So you've got over 18,000 young people who participated. Our methodology was peer reviewed and passed by an institutional review board. And there was wide reach. We did specialized outreach to be able to, through social media, target the young people that we wanted to participate in this. And the good news is, we were able to get people that are very relevant to California. And California is a large state, boy, you know that. And so we have a wide array of people who participated that were ethnically diverse, that were from different sections of the country, so a mix about geography, coverage, as well as their gender identities. And they were asked to complete a questionnaire of up to 134 questions, and here we go, they did. So what did we discover? Well, one of the things is you find out that suicide risk among this group of people is quite high. Nearly 4 in 10 of LGBTQ plus youth seriously considered suicide last year, and about 1 in 8 made an attempt. And in California, you can see it's pretty much on par with what the national averages were. So what are the causes? What are the crises? Or rather, what are the challenges that are being faced by LGBTQ young people that force them, or rather lead them towards considering taking their lives? So one of the biggies is anxiety and depression. 64% in California indicated anxiety, and 52% reported symptoms of depression. But as Dr. Renee pointed out, depression itself alone will not help you know for sure if they have suicidal ideation. So one of the other things, though, to go back to causes besides anxiety and depression, 50% of youth here wanted but didn't receive mental health care. So why might that be? Well, here are 3 of the big reasons why this has happened. One, they self-selected out. 47% of LGBT young people said they feared talking about their mental health with another person because they might be stigmatized about it. Another big concern and fear for them is having to ask for parental permission. And this goes back to one of the painful awarenesses is, and as Dr. Renee mentioned earlier, a high rate of rejection by families is one of the biggest indicators of suicidal risk among LGBTQ plus young people. But another inhibitor for not getting mental health care was that 34% of them said they couldn't afford it. Now, other reasons included things like I wouldn't be taken seriously and really being afraid that someone would call the police or involuntarily hospitalize them. So when we get to when you're doing screenings in your room, and if someone does present at high risk, part of what we say is, if you can help develop a plan and help move them forward, this is wonderful. But the first call would be to try to refer them to a mental health person and or to a 24/7 service like the Trevor Project or 988, rather than moving to asking the police to come in and take them somewhere. That can have adverse effects. So this is why knowing what the resources are that you have is going to be so important in making a life-saving difference. Another reason that young people have decided that that increases their suicidal ideation is that they discriminate, that they're discriminated against, and that they are physically threatened or harmed, or instances of bullying, which can be verbal or online. And as you can see here, you know, half the young people in their teens, 13 to 17, experience some kind of bullying. And 18 to 24 is still a high at-risk group. And you've got over a third of them that are also experiencing bullying. And last but not least, I think we're all aware that there's been a very pronounced effort to stigmatize and diminish LGBTQ youth, but particularly trans and non-binary. And how does all that rhetoric impact our young people? Well, quite seriously. And almost half of California youth have said that recent politics negatively impacted their well-being. So this is part of why we say we cannot underestimate the threat this places on young people's lives. So what can you do? One of the things I want to say is, beyond crisis responses, prevention, and let me pause for a second. You know, Trevor does crisis intervention, which means you're there in the moment of need, acute need. But part of what we also do is the larger thing of trying to stop them from getting into a moment of crisis. And that's what suicide prevention is all about. And this is where you can help. You know, one of the things with prevention is it starts with how safe does a young person feel in your space. And simple things can go so far. And it's things like saying, what pronouns do you use? You know, one of the things when we started this, I think I forgot to say, you know, that my name is Peggy Breisky and I go by she, her. And there are a lot of folks who it's not so much comfortable for them to do that. But I will say, if you ask a young person that, and if they happen to be LGBTQ plus, you're right away letting them know that you're a safe port. So it's that simple thing. Just, hey, you know, nice to meet, whatever. And just curious, what pronouns might you use when you're meeting with a new patient? You know, having a small pride flag or a safe space sticker can actually send a very strong message. And when a patient of yours shares what's going on with them and their identity. 91% of LGBTQ youth said that trusting I know who I am is one of the most meaningful forms of support you could give me. Now, I think the thing is that a lot of research has shown that their pediatrician, you're truly one of the most trusting people in their worlds, and that they will confide in you things that they would not tell their parents about what's going on with them around their mental health. And that's why I think the AAP has come out with such a strong recommendation for including these screenings. You and your staff really are a lifeline for these young people. So one of the things that we ask or recommend is doing a little bit like what we do on a crisis line. You know, the first thing you do is listen. People want to be heard. It's not just true of people at risk, but it's definitely true of young people in a moment of crisis. Then you use your skills to observe. And you know how people say there's a difference between looking and seeing? You know, seeing takes in the whole person. It means nonverbal cue as well as verbal cues. It means your EQ. What are they avoiding? What do you sense? You know, might have shifted? Where might you need to ask a little bit more? Now, I will say, I very much, Dr. Renee has helped share with me the incredible pressure you're under when you're doing screenings with young people. You know, you're supposed to, you know, the insurance companies knock it out, you know, you're supposed to have 15 minutes, you're supposed to be moving people through. And the delicacy that's required and the care and compassion you bring to this sort of work against that. So all I can say is, you know, you have years of experience that you're bringing to bear here. And this is what we talk about when we say, you know, to observe in all ways about what's going on. And then the great thing is, you know, you use your discernment about what's appropriate to do next. And one of the greatest things what I feel about when I ask and we talk about being discerning is it's about being non-judgmental. There may be a lot of reactions you're having, but one of the most important things is to not discount what a young person is sharing with you or minimize the severity of what they're reporting to you. There's a statistic out there that among our LGBTQ young people, you know, the time it takes between when a suicidal thought pops into your mind and the moment you might take action can be as short as 5 minutes. And I think there was a survey that showed for 25% of people, that's how quickly it happened. And there was another survey, or rather in the survey also demonstrated that another 25% said it took maybe from thought to action 20 minutes. That's why when we're talking about, and Dr. Renee mentioned the statistics earlier about how quick the answer pickup rate is on a crisis line, that's why it's so important. The 988 line shares that it's under 1 minute. That's pretty important when you might be talking to someone who actually has thought that they want to do it, developed a plan, and actually has the means. These are the kind of calls we get. And the good news is that no one is asking you to be the person that takes them when they're in an acute state. You don't have to be a mental health practitioner, but you can help be the conduit to getting them to the person who is, or a crisis line that is, where there are, in fact, trained people to help in these exact instances. So, next slide. So what are the things you can do? Well, first and most importantly is incorporate this protocol into your office screenings. As I realize that most of you do some kind of intake survey, I'm guessing, usually sometimes and often digitally. Here's the great news. That digital intake survey is your friend. Young people will share stuff digitally that they may not verbally. So you might notice that the ACE-Q has great resources on this, and about, as Dr. Renee shared, a very simple 4 to 5 question screening thing. Some of that can be done. There are variations on that you might be able to incorporate in your digital pre-screening with young people, especially new patients, that could help start to give you insight and help you direct the kind of questions you're going to ask, including, sharing with them very directly that, have you had thoughts about ending your life? And have you, thought about how you might do that and made a plan to do that? And I think for folks who've never had to say this out loud, it is still nerve-wracking. I knew it was news to me, and that I grew up in a time and a place where I was worried I would plant the idea in somebody if I asked about it directly. And just as Lisa's scared about that there are certain well-meaning things we do that for certain groups might not actually be the support we hope we're giving them. One of these things is, what young people do respond to, I've found more often than not, and you would know since they're your client base, but is with honesty. And I think being able, and the research has shown, being able to ask this directly is one of the best ways to really find out and make a young person feel seen and heard. So anyway, I trust the right moment and the way in which to bring this up, and just sharing that this is now because you care about them and know how serious an issue this is for this age group, that you just want to check in and ask about this. Has anything like this been going on? Are you experiencing any kind of, ideas about not things aren't going so well? You might be thinking, I don't want to be. I'm thinking about maybe it's better if I'm not around, that it might be better if ended your life. The other thing is, when you're looking for risk indicators and factors, one of the things that you can ask about is, have you seen and known of any previous attempts? Do you see them expressing hopelessness in general about what's going on? And certainly, have you seen or witnessed in any exchanges any kind of sense of family rejection? Have they demonstrated or discussed signs of bullying? You do screen for physical harm, so I know that that's an opportunity to ask for that. And just, are there major stressors going on in their life? And when a young person does share that, I'm going to say the obvious, which you probably already know, which is, don't dismiss it as just a phase. And also, one of the things that's hard to do is to not make assumptions based on how they present their gender or what their preference might be for gender and or their sexuality may or may not be apparent to you, or seem to be apparent to you based on how they come in the room. And that's why we always recommend just ask, don't assume. The next thing up is, certainly if they share something, you want to stay calm and validate it, which we've talked about. Dr. Renee talked about all the ways in which you can determine what level of risk As we say, if it's an immediate danger, you'll want to initiate emergency support. And that means, of course, that you yourself know, are you going to have someone who's able to get someone on a line immediately that is prepared? As we said, there are counselors and lines available to support you in this moment, support a young person. And also the great thing you can do is know resources in your area that are available. Practitioners who specialize in mental health and may also specialize in serving LGBTQ, the LGBTQ plus community. And we've already mentioned the 988 suicide hotline, but Trevor also has a whole passel of resources that can be helpful to you. And Yolanda, can you move on? So Trevor, first of all, there's a link here and you can get to our national survey. There's the California breakout that easy enough to get to. That's part of that information as well. We have our 3 portals of 24/7 support for a young person in crisis. Lifeline chat and text. There's a link that's also available here that will be shared that you can get to as well. But Trevor also has a resource center, which is not only great for young people, but it's very much for supportive adults, allies, and pediatricians. It has questions and answers to, gosh, just about anything you might come up with and want to know more about. And why this is important is one of the other things I'm going to talk about is one of the things that helps young people is when you yourself have taken the time to research some of the questions you might have. Particularly, I think most common is about trans and non-binary youth. And there are a whole list of terms and ways young people may choose to describe themselves. And the Trevor resource site can give you tremendous insight into each and all and any of what those terms mean. But more importantly, they're, for me and for folks I've referred to it, a kind of safety net, you know, where you can find a way to be more prepared to have what might seem like uncomfortable discussions. And again, you're doctors. I know you face this a lot more than most folks. But what I find in 30 years of doing this is that young people are always changing about how they want to talk about themselves. Certainly, the world has changed a lot around the issue of identity. And I think it's something like 1 in 4, the latest census results or research on this area about identity revealed that something like 1 in 4 young people under the age of 30 now identify on somewhere on the LGBTQ plus spectrum. So something is going on generationally. There is a major shift afoot. And resources like Trevor can help all of us stay abreast of what and how that is looking like. In terms of our last part, you know, just here are some of the most obvious, or maybe not so obvious, ways that young people talk about how you can support them. And I think it's really fascinating that over 90% said that I just would like you to trust that I know who I am. And another big one was the standing up for me. So what does that look like? You know, if somebody says something in a group that, you know, that is mocking, belittling, putting down, teasing, about someone's identity. We all know that that's so queer, and a lot of other terms and ways in which young people can be diminished, that being able to be the one that says, that's not so cool, would be a great way to help. And also, given the high rate I shared earlier about how over half of young people talked about politics of late has impacted their mental health a lot. It was nearly 50%. Not supporting politicians who promote anti-LGBTQ policies means a lot to them as well. And respecting their pronouns. So that last one, that's a biggie. It comes up a lot in the calls to our services. So folks, I want to thank you so much for allowing me to share this with you. And I really just want to say again, a huge thank you on behalf of all the young people we represent, on behalf of all the young people you serve, and also for all the parents that you also are a trusted ear for. You really are lifesavers. So thank you for that.
Thank you so much, Peggy. We really appreciate um, your your kind words and your encouragement and information sharing. So thank you. I'm sure that you've given us all a lot to think about as far as not just how we practice our pediatrics or healthcare, but also how we interact in the world with LGBTQ youth. So thank you. I'm going to ask Sana to put the next slide on. Uh, so our next speaker is Suzanne Rybczynski, who is the Chief Medical Officer and Vice President for Medical Programs at East Tennessee Children's Hospital, and the Interim Chair and Associate Professor of Pediatrics at the University of Tennessee Health Science Center. And she has worked a lot in the area of children with neurodevelopmental disabilities, and particularly autism, and has done some of the pivotal work in suicide risk screening for youth with neurodevelopmental disabilities. And so I'm going to turn this over to Suzanne. Thank you so much.
Thank you so much, Renee. I am going to share my slides. Uh, Okay. Oop. All right. My mouse is being sticky today for some reason. Hang on. Okay. There we go. All right. Can you see that? So thank you so much for having me come to this great talk. I'm really humbled, especially by the presentation by Lisa, to really hear the lived experience of an adult with who is autistic and has faced the realities of suicide on many levels. So thank you, Lisa, for sharing. I think a lot of my talk will build on what Dr. Wachtel and Lisa have already started to talk about. So hopefully it'll be informative and bring additional insights. I want to share my agenda. I want to talk about what a suicide preventionist is. It's a term I made up. Please share it, use it. And I'm going to hypothesize that everyone on this call is a suicide preventionist. I'm going to talk about the risks for suicide in youth with neurodevelopmental disabilities, actions we can take to identify suicidal thoughts and behaviors in youth with neurodevelopmental disabilities, and the outcomes and research from programs I've been involved with, things we've learned about screening youth with neurodevelopmental disabilities for suicide. So I just want to give you a little bit of my background. I'm a pediatrician, a general pediatrician, and also have worked as a pediatric hospitalist. My job prior to moving to Tennessee for this current position was at Kennedy Krieger Institute, which is a specialty hospital we had with focus on youth and adults with a variety of neurodevelopmental conditions. Conditions ranging from cerebral palsy, learning disabilities, autism, spinal cord injuries, psychiatric components, anything you can imagine that involves the brain, the spine, or nerves is treated at Kennedy Krieger. And it's there when I was working as a pediatric hospitalist on the inpatient pediatric rehabilitation unit that I became very passionate and a suicide preventionist because I took care of a lot of kids who presented to me in my hospital following a suicide attempt. Many of those kids had underlying neurodevelopmental disabilities, many did not, but all of them had stories that were just so impactful and tragic that I wanted to do anything I could to prevent tragedy. So having taken care of 11-year-old girls who had hung themselves and destroyed their airway and could never come off a ventilator, kids who jumped off of buildings in a suicide attempt after a breakup with their girlfriend, and then, youth who had incurred a spinal cord injury, were paralyzed, quadriplegic, newly, who were actively suicidal but couldn't act on it because they could not move. The pain there and suffering, I just felt like I had to do something to help. So here I am, a suicide preventionist. I think we're all suicide preventionists by just caring about kids and wanting to do something. So everyone on this meeting certainly would qualify for that. So thinking back to the time before going back around the pandemic time, there was a lot of awareness, increased awareness that kids were suffering from mental health distress. And the American Academy of Pediatrics, the American Academy of Child and Adolescent Psychiatry, and the Children's Hospital Association declared a national emergency for mental health for kids. And this was followed shortly by the Surgeon General's advisory addressing the urgency to treat kids for mental health conditions. Shortly thereafter, and Dr. Wachtel mentioned this, the AAP worked together with ACAP and the American Foundation for Suicide Prevention and the National Institutes of Mental Health to develop a blueprint for youth suicide prevention. And this really gave the guidance to pediatricians on how they should address the suicide epidemic that was hitting all of our communities. And this is an excellent resource. I would refer you back to this anytime. It really talks you through the different ways you as a pediatrician can make changes, whether it's direct patient care or community advocacy, and working with schools. It's a really good guideline for what you can do. So that bookmark that in your drive. And like Dr. Wachtel said, the recommendation coming from that was to universally screen all youth for suicide age 12 and up, and from ages 8 to 11 when clinically indicated. And you can see on this slide, there are different ways to do it. Dr. Wachtel mentioned the PHQ-9 being used as a screener, which has not proven to be adequate because it really focuses on depression. And other ways you can screen are including the CSSRS, the Columbia screener, and then the Ask Suicide screening questions, which is a whole toolkit for suicide identification and management in a variety of settings. And we'll talk a little bit more about that. So just to get back to the main topic, we know that suicide risk is evident in youth with variety of neurodevelopmental disorders. And there is a lot of people just don't believe that is even possible. So I'm here to tell you, yes, it is possible, and we need to think about it. A lot of the studies, including the validation study for the ASQ, specifically made ineligible kids with neurodevelopmental disabilities. So that's something to keep in the back of your mind when we're talking about the work that's been done at Kennedy Krieger about screening kids with neurodevelopmental disabilities. Those tools were not validated for kids like this. But we know that kids with intellectual disability have 2.8 to 4.5 times the risk of a psychiatric comorbidity. And we know that psychiatric comorbidities are associated with suicide risk. Suicidal thoughts and behaviors have been noted up to 42% of kids with a variety of neurodevelopmental disorders. Storch identified that 11% of autistic children have suicidal thoughts and behaviors, and it's frequently associated with depression and post-traumatic stress disorder. And in this last recent study by Vasa, who is at Kennedy Krieger, she is at the Center for Autism. They looked at 18,000 patients who presented to the emergency department with suicidal, who presented to the emergency department. And they found that autistic youth were more likely to present to the ED than non-autistic youth, and they were significantly more likely to screen positive for suicide risk. And this study was done at Hopkins ED, where they've been screening for suicide use or suicide risk for years in youth, and as a universal tool. So one of the things you have to worry about is a thing called diagnostic overshadowing. That's where the focus of the care is solely on one diagnosis without thinking about other potential causes of symptoms. And I think Lisa referenced this. You know, when you're just seeing one thing in a patient and you can't even imagine there could be other things going on, you miss things. And that's one of the things that is a risk for kids with you know, a variety of neurodevelopmental NDD causes. So sometimes this is a kid who is nonverbal for whatever reason. People don't ask it how they're feeling. They don't even address the possibility of suicidal ideation. Or like I mentioned before, you know, a patient who I met along the way with a new spinal cord injury, you know, they couldn't do anything about being suicidal, so people weren't worried about it or didn't want to talk about it. And that is just heartbreaking to me, to think that the level of suffering for that patient in particular and others like them. So in autistic individuals, we know that there's a higher risk for mortality in general than those who do not, or who are non-autistic. So that's across the board. We know that people on the spectrum have excess mortality, and that those who do not have comorbid intellectual disability are more likely to die by suicide, period. Those who do are more likely to die of medical complications, especially related to epilepsy. And we know that suicidal thoughts and behaviors are notable in all ages of autistic individuals, up to 50%. And that overall, when you think of all suicidal people, 15% are autistic. So this, you know, the thought that this is not even a possibility is just a myth. And really, we're here today. I think everyone here would join in trying to break that misconception. So some of the risk factors for suicidal thoughts and behaviors we've talked a lot about, and we know that kids with NDD are not immune from these.
Just wait up there, you know.
So we know that psychiatric comorbidities like anxiety, depression, impulsivity is a huge factor in suicide attempts, which has been mentioned. And that can be seen in kids who have, you know, who have comorbid ADHD. So those kids are impulsive. They're faced with a challenging situation that's inconceivable amount of pain, and they make impulsive decisions that can lead to death and morbidity. Having a serious health issue or chronic illness, that's a lot of the patients that we see at Kennedy Krieger have chronic health problems. That makes it a risk factor for suicidal thoughts and behavior. And then prolonged stress, such as peer victimization, bullying, isolation, when you can't make friends because of that. That has been mentioned, not only for the ASD folks, but also, as we were mentioning, for LGBTQ plus youth. And then we're going to talk a little bit about camouflaging that, when you think about prolonged stress, and as a young person trying to fit in really hard, especially autistic individual, they're working really hard every day just to keep it together and not stand out. So that's where Lisa was talking about camouflaging. That's things like using compensation strategies, like using a script to compensate for being in challenging social situations. Hiding your real persona through portrayal of a non-autistic individual, or just trying to fit in social situations, forcing yourself, gritting your teeth to get in there to avoid social exclusion when it's not comfortable and it can cause distress. So I want to just talk about the work that was done at Kennedy Krieger. I mentioned it's a center for youth and adults with multiple types of NDD. And back in 2016, way back before the pandemic, there was a real concerted effort to address this, which was pretty innovative at the time. And it was triggered by the Joint Commission. So as a hospital administrator, it's something I think about a lot. And the Joint Commission, before things become a rule, they become a Sentinel event alert. So the Sentinel event alert was screen all patients for suicidal ideation using a brief, standardized, evidence-based screening tool. So that is what was taken to heart. So a task force was developed, multidisciplinary, including medicine, child psychiatry, social work, nursing, psychology, hospital administration, and set forth to really think about how we're going to do this. How can we identify these kids and get them the help that they need? Because we know they don't get help if they're not asked. We were lucky to be affiliated with Johns Hopkins. The School of Public Health is right across the street, so they were able to help us really address the best way to think about rolling out a suicide risk screening plan. So we're lucky to have those resources. And we are also lucky to have friends down the street at the National Institutes of Mental Health to help with this too. All of the staff were provided education on the screening protocol prior to implementation. And I can tell you that there were several physicians who were just like, I don't want to do this. This is ridiculous. Why are we doing this to our kids? And we had to work through their feelings about that and really provide that education about the importance of the protocol and the plan. And the protocol initially was rolled out in medical clinics only. And that was very intentional because it was thought that in behavioral health clinics, like psychology clinics, social work clinics, where therapy was being provided, that those folks were doing their own suicide risk screening already. And also they didn't have a nurse. So we were targeting clinics where our nurses could do the suicide risk screening in triage with a positive screening resulting in notification to the attending or nurse practitioner in clinic, and then a further suicide risk assessment would be performed, a safety assessment. And we use the BSSA, which is part of the ASQ toolkit, which Renee went over the questions already. But you can see that these are pretty, direct questions. and they were seen to be pretty harsh. So we talked our nurses through this for a while. But once they understood the ramifications of doing this screening and how we could help kids, they were fine. We did start our screening at age 8, which is below the recommendation for universal screening from the AAP, knowing that kids, especially those kids with who are autistic, had an increased risk for suicidal ideation. We wanted to identify kids as soon as we could. So we took a look at how this went for the first 6 months of our protocol. And you can see that we were looking at eligible visits, so not individuals. Kids could be screened multiple times in this study. And we completed, there were over 5,000 eligible visits in the 6-month period, and 3,800 screenings roughly completed. There were a lot of declined screenings. We were aware that there were some kids who were just physically unable to complete the screenings, and we left it at the discretion of the patient or the parent to decline. So the results were pretty interesting. Across the board in all our clinics, the percent of positive screening events was at 6.8%. So not 0. So clearly kids with neurodevelopmental disabilities have suicide risk. And you can see from this slide, there's a wide range. In our autism and related disorders clinic, the rate of positive screens was 12%. Other clinics that scored above our rate or overall rate for the organization included neurology clinic, concussion clinic. We know there's a correlation between concussions and suicide attempts, neurological conditions or chronic conditions. So these are the risk factors that are playing out in real time based on our study. Chronic pain, having a chronic illness, especially chronic pain, leaves you at high risk for suicide. That rate was high. And then, you wouldn't think spina bifida clinic, high rate, and continence clinic and Sturge-Weber clinic, while their ends were small, they still were significant. So we were, that was 6 months. And we've been doing this for years. So we wanted to make sure we were doing the right thing. So we took another look at this protocol and looked at visits to Kennedy Krieger, initial visits only. So these are the first time the kid walks through the door for an assessment. And we came up with some interesting results, which really validate the protocol and that this should happen across the board. Kids with neurodevelopmental disabilities should not be excluded from screening protocols. So if you look at this, we had a similar rate of ASQ positivity at 7.3%. But 10% of those who, like the 7.3% positive, reflected all potential visits, but of those who actually took the screen, 10% were positive. Not surprisingly, we had 11.8% were positive in our mental health clinics, high rate in psychiatry and neurology, consistent with what we saw before. Developmental pediatrics, so those are kids with learning disorders or ADHD, things like that. They had a lower rate compared to the overall organization. And you can see that our rates in our autism clinic were about the same as previously indicated. We were right at around 12% there. And you can see the different groups of clinics here together. One of the things that we realized is that therapists are less likely to let someone have the option to not do the screening. So when we looked at declined rates, you can see the mental health clinics, only 1.9% declined. They really weren't, I think the presentation of the screening is very different by the nurse versus the mental health clinician. So that's a pretty interesting takeaway. And then when we lumped all the different types of clinics together, we had some interesting results. We found that in medical clinics, all the medical clinics together, young women and older kids were more likely to screen positive, along with those who were reporting their own or answering the questions themselves. Within behavioral health clinics, similar results, female and older kids were more likely to screen positive. But within our autism specialty clinic, we did not have that same breakout. There was no age differential and there was no sex differential. The only thing that made significant, that was statistically significant, was that if the child reported that they had suicidal ideation or screen positive, which is significant, which makes me think caregivers may not have any idea what their kids are going through. And that really gives evidence for it, especially in our autistic youth. And I think this, if there's one key takeaway from this, this last slide, is that we had positive screenings and all clinic types across the board in every age group, going down to age 8. So kids as young as 8, probably younger, which was mentioned before, are thinking about suicide. And we can't just ignore that fact and not believe in it, because it's real and we have evidence for that. So we know that the ASQ was not validated in kids with neurodevelopmental disabilities. No, so we are working on an alternative screening tool with our colleagues at Nationwide Children's, the National Institute of Mental Health, with funding from AFSP, and giving kids in a variety of clinics the ASQ and comparing it to other questions to see if they're valid. So we want to make sure we're asking the right questions to kids, and figuring out if the ASQ as it is written right now is okay, or if we need to change things, make an alternate version. So we have completed our recruiting for that, and we're in the data analysis phase of the study. One of the things that is interesting from this study is we are looking at that, you know, are kids focused after the research visit? Are they thinking about suicide more because we talked about it? So there's a follow-up questionnaire given to the parents a few days after they have the visit and the questions are asked. You know, are they talking more about suicide? And preliminarily, we're not seeing that. It's not something they're focused on. And those who are talking more about it feel validated and happy that they were able to open their discussion with their parents about how they were feeling and suicide. And just a shout out to my colleagues at Kennedy Krieger. I'm still lucky enough to be part of the research community there. We started in 2022 looking at all this data. We have a lot of data. I think there's a lot to learn. One of the projects that we're currently working on is looking at the outcomes from repeated screenings. So it's not clear how often you should do these screenings. In a patient who has screened negative, do you keep going? How often? So we're trying to figure that out and provide guidance on that. So I think that is my last slide. And I want to thank you all for listening, and thank you, Dr. Wachtel, for inviting me. And I think we'll go to the question session.
Thank you, Suzanne. That was extremely helpful. I think we have a number of questions related to parents. What about parents who don't want to leave the room? What about parents who fill out the forms for their child and don't ever ask the child? And what about the parents who decline to participate in doing the screening? What are your thoughts about the reasons for that? So three related questions about parents and screening for suicidal risk.
So I can tell you the experience that we had for declined screening in kids with NDD. Some of that, the majority were related to just the physical inability to complete the questions. some of them just absolutely denied the fact that there was a potential thought about suicide. So really being able to have a script, and the ASQ toolkit provides a script for parents onto what as to why the screening should happen. So I'd recommend taking a look at that and adapting it or using it. But I think the majority were really unable, cognitively unable to complete the form. And I would say that having, I think at age 10, we asked the parents to leave the room when the screening was performed. The ASQ was developed specifically for to have it spoken to you, not written. So it's a if done as intended, it's a verbal conversation.
Thank you. Another question for Peggy. There was a comment about how some practices have a significant number of Spanish-speaking families, and whether the question was whether there are materials about LGBTQ and suicide risk and so on that, or even just support that are in Spanish. But I would broaden the question to ask whether your perception is whether there are cultural differences in the acceptance or rejection of LGBTQ youth in Spanish-speaking families.
Thank you for that. The 988 line does provide counseling in Spanish. Trevor itself is actually international, and we do have operations that are based in Mexico. Currently, we do not have Spanish-speaking services on our three crisis lines for Trevor's classic services ourselves, but it is a thing that we want to do and are moving toward. I would say that, to be honest, the indicators of what constitutes support versus rejection and things that increase suicidal ideation remain the same. Culturally, the thing about coming from a rejecting family crosses cultures. I've not found that it is isolated to one based on race or an ethnicity. It's really a challenge. So so that is what I would say about that. I do think, as I said before, I would happy to recommend you to really, if you can, peruse the mental health survey we did. It will help illuminate a lot of that, as well as we have the surveys also available on our resource site that are also relevant for folks who are Mexican American families. That does provide a lot of insight into what it's like for youth in Mexico.
Thank you. For Suzanne, there's a long question, but it basically is how were you able to get the universal screening incorporated into the clinic workflow? Did the pediatricians or nurse practitioners have time to do suicide assessment and resource referrals and so on? How was that managed in a clinic workflow?
Yeah, that's a great question, because that's like the big deal for pediatricians. Once you have that screening, what do you do when it's positive, and how do you not derail your whole day? And so at Kennedy Krieger, they established a protocol where a positive screening, you had multiple options. You could do the ASQ's BSSA as the physician or nurse practitioner, and we're very lucky to have a lot of resources to phone a friend. So you could call a social worker in who would do it, or a lot of the clinics were multidisciplinary. So there would be an embedded psychologist or even a psychiatrist in some of the clinics where they could address those positive screenings. They did develop a system in the medical record to like flag prior positive so that people kind of had a heads up that they knew this patient had had a prior attempt. And the majority of the positives are prior attempts. And if you look at the ASQ workflow, there's a part of the algorithm is if you've had an attempt and it's a remote attempt, I think a year remote, your parents are aware and you are in therapy or have had therapy, that's not considered a positive screen. And I think that's one of the key things to think about when you're doing it. The rates of positive acutes are going to be low. The rates of positive because of a prior attempt are going to be high. And it's that in-between group that developing a workflow in your office is really important. And the BSSA is not a full psychiatric evaluation. It's really a determination to get to the next step of care, whether that is seeing a therapist in the next 24 hours or going to the emergency department for a full psychiatric evaluation. So I think it's challenging. It does derail, but the really important thing is that relationship you have with your patients as a pediatrician is so vital, and you're going to know these kids, and to go through the BSSA, it's such a great tool so you don't miss things, so you can really work through it. So it's very different in the Kennedy setting versus in a community pediatric setting, and I recognize that it's very different.
Yeah, and just to let people know that the clinical pathway is in your handouts, as is the other resources. So thank you, Suzanne. One question for Lisa, and then we'll take our break. Um, there was a question about whether you felt that you got the support you needed when you were cared for as a youth, and whether that could have been done differently at that time.
As a youth, as a kid growing up in the 60s and 70s, autism really wasn't known, especially in girls. So I had things like a lot of stomach I issues that were just basically they finally told my parents to tell me to go out and play. Um, a lot of falls, just not being in my own personal space very well. But I was just quiet and didn't have any friends and, was bullied like the experience of many autistic people my age. But no, there was no help. There was no support.
Well, hopefully we are making improvements in that. So thank you. So why don't we take a break and come back at 10 after 5, at 5 after 10, so that people can have a bio break, and then we'll resume. And I want to thank all of the presenters for your great insights and sharing your stories. So see you at 10:05. Like to welcome everybody back after our bio break. Um, I guess one of the great things about doing Zoom conferences is that we can know exactly what time it is and get started right on time. So, our next speaker is Ton Hall, who is the executive director of the Miles Hall Foundation, which is dedicated to ensuring families in mental health crises receive the care that they and their family need, and not criminalization. And she is going to be talking about um, how the foundation helped to pass AB 988, the Miles Hall Lifeline Act, establishing an alternative to 911 for mental health emergencies in California. And she has also spearheaded the launch of the Miles Hall Crisis Hub, a 24/7 non-police crisis response center in Contra Costa County. And she is going to be talking about what to do next, 988 or 911. Thank you, Ton, for sharing with us.
Great. Thank you guys for having me here today. I just want to say I am truly honored to be in this space with you guys today. And I'm just really grateful that I was invited. And I really appreciate all the hard work you guys are doing to prevent suicide prevention. So thank you, Dr. Renee and your team. And of course, this is a disclosure, which you guys already know. And as Dr. Renee explained, I'm going to be talking about, in my experience, how serious mental health response can be deadly when 911 is involved. And then also how trained counselors can de-escalate and support families with compassionate care. And that's 988. And then also just to remind everybody that how powerful we can be when we want to change systems and make policies that are going to be different to affect our families and to our people that we're protecting. So, as Dr. Renee explained, I'm Ton Hall, the Miles and the founder of the Miles Hall Foundation. This is Miles, this is our family. Miles was 23 years old when he was killed by police. And unfortunately, we had really tried really hard to get Miles help. The system's a very reactive system, not preventative. I saw signs of him having mental health struggles with schizophrenia, and there was really no resources for us. And unfortunately, 911 was one of the only ways to get my son help, who, where, as we know, we have to be a danger to self, danger to others, or gravely ill. And unfortunately, there were no other resources for us. And 911 was called, and Miles was killed by the police while experiencing a schizophrenic mental health emergency. And Miles had big dreams. He wanted all the things, right? The wife, the house, friends, but he had serious mental illness. And as we know, it's very difficult to get someone who doesn't understand they're not well to get them the right care. And Miles didn't need 911 the day that he was killed. He needed someone that we could call to give help, to be on a line to support. And that was not an option when we needed help the day that he was killed. And, I keep going back to the fact that the system is just very, very reactive and not preventative. And I think as families, and I mean, as you guys are professionals and trying to make sure that your constituents, when they are needing the help and care that they need, that now that there is, an option for them to be able to call the 988 number and receive, help that's going to be on the other line. So that's going to be making sure that there's a trained counselor to talk to them and make sure that they can provide that compassionate, non-judgmental support, to make sure that person feels heard. And then also just making sure that they have the active listening and de-escalation techniques that are necessary. Making sure that there's safety planning, right, that on the other line with 988 provides. And then also the connection to local resources, which again, the day before Miles was killed, I actually did call the non-emergency line, because there's a big story to our story, which I'm not getting into. But we had developed a relationship with the police to make sure that what happened to Miles wouldn't happen. And I had called the day before to the non-emergency line to try to just make sure that, the police would know if someone had called the police, that just Miles needed, compassionate care and not and not um, and not police. We had called just to make sure that they knew what was going on with his what he was having delusions and hallucinations. And when I called the day before, there were no resources available. There were no resources offered. There were no mobile crisis units offered for us. And if there were, there's very good chance that Miles would be here today, because he would have had a mobile crisis unit that would have come to our house the day before he was killed and would have de-escalated Miles and made sure that there was someone who was trained, who had, hours and hours of experience, not a police officer who only has 14 or 15 hours of mental health emergency training. So this is obviously something that 988 would have been very helpful for us to have. And now my son is not here because we didn't have that. So, I just want to make sure that, and as I'm sure you guys all know how important this number is. But in California, and I'm not sure if you guys all understand how California is different than the rest of the nation. In California, we were able to pass AB 988, the Miles Hall Lifeline and Suicide Prevention Act. And what that was is because I went and was basically door knocking on legislators' doors, trying to find someone who would listen to us. This is after Miles was killed. But I was like, we have to make something, we have to make change. We cannot let this happen to somebody else. And I was able to find Rebecca Bauer-Cain in Orinda, and Assemblywoman. And she said, well, the day before you called, if there was another number that you could have called, that might have saved him. And I said, yes, absolutely. So she basically expanded the national 988 number. And what we did was we made sure that now all counties in California have to have a mobile crisis unit. So, and that's so important for, potentially some of your constituents and people that you guys are caring for, because, a mobile crisis unit may come out when it wasn't an option for us. And some of the roots of this problem, as we know, the mental health stigma, right? The criminalization, the systemic racism. My son is Black. And, and as we were talking about, your constituents who might be LGBTQ2, they also are also, have the stigma as well. So these are just some of the things where, as I mentioned with our advocacy, we were able to make sure in our county that there was a mobile crisis unit. So even before there was AB 988, the Miles Hall Lifeline and Suicide Prevention Act, which is a statewide initiative, we created a local initiative in our county because, as I mentioned, I called the day before, there were no resources. At the moment when I had called, there were only, I think there was one mobile crisis unit that would have come to your house, but it was Monday through Friday, and it was like 9 to 5. So now, because of Miles's death, because of our advocacy, we now have a 24/7, 7 days a week mobile crisis unit that will come. So this is, very life-saving in our county. But as I mentioned, that AB 988, the Miles Hall Lifeline and Suicide Prevention Act, all counties in California have to have this mobile crisis unit that we now have in our county. So, it is hopeful that, other counties in California are going to have what we now have in our county and Contra Costa County. So, yeah, I mean, as I hear and I'm speaking to you guys, I think you guys all understand the importance of us having another number besides 911, because 911 is, again, in that criminalization. It's in the potential to overreact when people come with guns, and 988 is now a compassionate um, a way that families, or a compassionate way that now we have people who are trained like yourselves, who might come out and help with someone in a mental health emergency. So you guys have all these slides in your deck, but our mission is definitely to advocate for individuals and families impacted by mental illness, educate communities to reduce stigma and bias around mental illness, and prevent criminalization and excessive use of force by law enforcement during mental health emergencies. And I'm very proud to say that with AB 988, we are going to be able to prevent some of those criminalizations and excessive use of force by law enforcement. So my board of directors, we've done now a lot of education in schools, talking about 988, talking about, how police are important in our communities, but not necessarily to be the ones to support us in mental health emergencies. Our legislation is where 988 comes from. We also support families who, are like us, who need help with therapy. And this is a picture of one of our youth summits. And as I mentioned, A3 is our local Contra Costa County Mobile Crisis Unit. Now is going to be, as all counties in California are going to be mandated to have that. We have it here. It's in Alameda County. It's in San Francisco. There's a lot of places that now have it. But yes, so yeah, so I just, please follow us on our social media. We are definitely doing a lot of different work, and want to make sure that especially people, on this call know about the work that we're doing and how you do. And just as we continue to make change in our communities.
Thank you so
So,
much.
yeah, so thank you again for having me here today. And yeah, I'm just again grateful. And as I always say, when I'm done speaking about Miles, I always say his name, Miles Hall. But there are so many others behind us that are also in situations where police should have not been the first responders, and that's why we work really hard to make sure that we have another response that doesn't involve criminalization and police.
Thank you
Thank
so much, Ton. And I want to encourage everyone to look into in the county that you practice in and in the county that you live in about how to access the mobile crisis team. And also, while all counties are required to have mobile crisis, not all of them have the funding and support to operate 24/7, 7 days a week. And so you should find out what the operational hours are in your counties. And if it is not 24/7, 365, you should be advocating for those expanded hours, because mental health crises do not just occur 9 to 5, Monday through Friday, as we all know. And it, there are funding that is given to every county through the Mental Health Services Act and other sources of revenue that that can be allocated to that if there's a sufficient advocacy. So thank you, Ton, for
Yeah.
bringing that up. Much appreciated.
Oh, thank you. And then just one other quick thing. I did want to say just with California and how we are different, right? Of all the states, there's not that many that are using telecom for their funding. And California is one, just like 911 is funded. 988 is now funded by the the taxes on your telecom with your phones. So just, California definitely has the funding, which is very powerful, where a lot of other states may not have this right now.
Thank you for bringing that up. I wasn't aware that it was
Yeah.
funded that way because there's a challenge to the funding for the national 988, but it's good to hear that we in California have our own funding stream. So that's
Yeah, which is really, really important because it is sustainable, right? It's going to be sustainable here in California. So again, California, we are leaders, right, in so many different ways, and this is another way that we are. So thanks again.
applaud to you for all your advocacy.
Thank you.
Okay, Sana, do you want to put up the next slide? So our next speaker is Jennifer Ledecker, who is the clinical program manager at the Children's Health Council for the RISE Adolescent Intensive Outpatient Program. And she specializes in DBT, dialectical behavioral therapy, which is a specific approach to complex problems that adolescents and their families face during and after crisis. She has had a long history of working with families through the RISE intensive outpatient therapy program. Uh, and she's going to tell us about how dialectical behavioral therapy for suicidal and self-harming adolescents is a specific, effective therapeutic approach that we can refer our patients to instead of just sending them for non-specific behavioral health therapy. So thank you, Jennifer. We look forward to your talk.
All right, let me share. And then, can we see the slides and everything? Okay, perfect. So I'm Jennifer Leidecker. I am the clinical program manager for the RISE Intensive Outpatient Program. And my role and the RISE program was developed in 2017 following the Teen Mental Health Initiative at the Children's Health Council that was in response to the second suicide cluster that we had in Palo Alto at our high school. And so this has been something that we've really focused in on at the work that we do at CHC and RISE specifically. And then we're also a partnership program with Stanford Children's Health and their comprehensive DBT outpatient program as well. So my disclosure. Today, the learning objectives that we're going to go through are identifying clients that would benefit from DBT, understanding what the 4 key treatment components of an adherent DBT model for adolescents are, and then also understanding the DBT skills modules and the various areas of dysregulation and kind of problems that they address. And that's both for parents and for the teams that we are working with. So dialectical behavioral therapy was developed in the 1980s by Dr. Marsha Linehan out of the University of Washington. She originally was working with women at high risk for suicide with multiple suicide attempts or non-suicidal self-injury in their past. And that kind of led to also working with women that were diagnosed with borderline personality disorder. So that was the original client population. We talk a lot in DBT about looking at the synthesis of change and acceptance. And the way that that was developed when Marcia was doing her treatment. When she came in, she was a behaviorist by training, and came in very strong with cognitive behavioral therapy and behaviorism strategies. And her clients felt really rejected, that we were really pushing for change in that treatment. And then she kind of went to the whole other side of the dialectic and was pushing their clients in using acceptance strategies. So coming in, being really validating, focused on kind of being able to tolerate and accept their levels of distress and the problems that they were experiencing in their day-to-day. And in both cases, her clients would get up and walk out of the room. And so where we are now in DBT is this dance that we do with our clients, in that idea of going back and forth between acceptance and change. So this is modeled both in the skills that I'll talk through, but also how I work with a client in the sessions as well. The other piece is mindfulness is completely integrated in kind of our foundational set of skills, and really set the stage for our families to be able to recognize those warning signs that were talked about earlier, and kind of that rising crisis when they're in that space. DBT is also very driven by protocol. So I'll talk through a little bit about what individual therapy looks like. And the ultimate goal of DBT is to build a life worth living. So while DBT is the only evidence-based suicide treatment for adolescents, and I'll talk through there's a couple studies that have, there's a third one that was just added to that list. Our main goal is to build a life worth living, because we really have to balance that idea of wanting to stay alive with something to be able to stay alive for. And then in 1995, DBT was adapted by Jill Rathis and Alec Miller, and since then has become the leading evidence-based treatment for high-risk multi-problem youth. So the driving theory that we operate out of in DBT is the biosocial theory. And so what that looks like is that we see our clients as having a biological vulnerability, both to their emotions, but also impulsive behaviors. So with their emotions, what we notice with our teens is that they have this emotion vulnerability. They are not only vulnerable to their emotions, they're really sensitive to changes in the environment. So they're also very vulnerable to the kind of space of like how their parents are responding to something that they're saying. So they're picking up on those tiny cues that other people might miss sometimes. And with that vulnerability comes a high reactivity. So we do see our teens who you might hear from parents that are like, I don't understand why they responded this way. They went from like 0 to 100 over something that nobody else in our family responds to that way, or are like none of our family ever really talks through what that looks like with them. We just see them react and then they disappear, and we don't really understand.
AirPods are giving me trouble. There we go. And then the other piece with our teens is we see this really slow return back to baseline. So they stay in this really high emotional state. And then from there, it'll take them sometimes, we've had teens say like hours to come back to what their baseline is. And then we also see that they can be easily kind of re-triggered while they're on that slow return. So their emotion kind of lability will be up and down along the way until they go to bed that night. And so for families, it's really hard to kind of navigate that. And the other piece to that, you add in the emotion vulnerability and sensitivity, and then this impulsivity, like Peggy mentioned in her discussion, that there's research around the idea that from like thought to action in terms of a suicide attempt, it's 5 minutes. These are our teens. These are the teens that they can have an impulsive, like a impromptu suicidal thought, and then will kind of come up with an idea and move really quickly towards a suicidal behavior or a non-suicidal self-injury like cutting or burning, which is something that we also address in DBT. The other side of the biosocial theory is the invalidating environment. So with that, we recognize that we are all doing the best that we can in any given moment. And for some of us, we receive messages that our emotions are incorrect. They're weird. They don't make sense to the people around us. And that can be cause us to not trust our emotions or try to kind of mask and fit in with the people around us, when in reality, internally, there's a lot of emotional distress and a lot of emotional experiencing happening that they just don't have the skills to navigate. The other piece that we see with our families is that sometimes our environment unknowingly can reinforce those big emotional outbursts or those like suicidal crises. And so it can be that we'll see teens with a lot of school refusal and they're really anxious about going to school. They'll make a statement to their parents like, if you make me go to school today, I'm going to die. Um, Parents will then keep them home. That actually reinforces that high crisis situation for them. And so that's sometimes where they start out later down the line. And with that, we recognize that even for us as clinicians, sometimes we are trying to figure out what is being reinforced, what is not, how do we navigate that with the family to really support them in changing that. And then the last piece of the biosocial theory is the transactional environment. In any given moment, and we share this and kind of talk through this a lot with our families once we're doing the skills work, is the interaction between the adolescent and their environment. Sometimes the adolescent isn't able to be skillful, and the hope is that the environment can be skillful and kind of reflect back. So that kind of back and forth that we see with our teens and their environment, with their friends, with schools, with home life, interacting with other like professionals like pediatricians, being able to be validated in that experience is really important sometimes in demonstrating that understanding of where they're at. And so for all of our families, they hear this discussion multiple times for them to really develop a deeper understanding of their teen in a lot of ways. So the evidence-based model of DBT for our families. So I know sometimes we'll receive referrals to RISE and CHC that a provider had recommended DBT services. And so in its true form, DBT for adolescents is a 6-month treatment commitment. Commitment is a really key aspect to the work that we do in DBT. Both commitment to engage in all modes of treatment that we offer and also commitment to take high-risk behaviors off the table. So we integrate that as part of our intake process, getting to know the teen, and then also working towards that idea of increasing their ability to tolerate distress and problem solving. And so as part of that 6-month commitment, they are agreeing to engage in individual therapy at least one time per week, a DBT multifamily skills group. So this is where the evidence-based skills of DBT are taught both to parents and teens. And each program can do it a little bit differently. In its true form, parents and teens are learning the skills side by side with the goal of practicing those skills. And as part of multifamily skills group, there is a homework assignment to that with the goal of integrating those skills into their day-to-day. And then the other really key piece for our high emotion vulnerability teens is that 24/7 phone coaching. So teens are able to reach out to their individual clinician for kind of any time of the day. I've been on the phone at 2 a.m. with some of my teens who are in kind of that crisis after getting a text message from a friend, or supporting them while they're on site at school and really struggling with an assignment or receiving a grade that they were upset by. And so we offer that 24/7 phone coaching to help in the generalization of the skills outside of program. We also use it for good news too, which is really great. The teens will set up a plan in individual therapy. They will execute the plan and then they'll call us and be like, it worked. This was amazing. And we get to also really reinforce their skills use through praise and a lot of cheerleading as well. And then the last component of adherent DBT is our DBT consultation team. So within that team, for us in RISE, because we're a multidisciplinary team, and we also integrate trainees into the program, our program integrates the consultation team from our like MFT and predoctoral trainees that we have with us, all the way up through our chief medical officer that's also supervising our fellows for psychiatry in that consultation team, with the goal of kind of therapy for the therapist is what we say, in terms of how do we support one another in both increasing our skillfulness as a therapist, making sure that we're doing adherent DBT, and really working to decrease burnout. So we work with really high risk teens and complex families. And so this space is really defined as the place where we do work to ensure that we're providing adherent treatment. So I had mentioned the skills of DBT. So within DBT for adolescents, there are 5 modules of skills that we go through. And within that, in the original kind of setup with Marsha Linehan, the middle path skills were part of interpersonal effectiveness for the adolescent units. We recognize pulling them out and really highlighting them as their own set of skills. Our walking the middle path skills are also the things that we work on more closely with our parents. So this is the idea of increasing dialectical thinking. So being able to balance 2 opposites in the moment. You think of like parents and teens kind of on both sides of like both poles for like curfew or wanting to go out on a school night. Like teen has their perspective, parent has theirs. And sometimes they're really entrenched. Using dialectical thinking strategies, we're able to kind of find what we call the middle path. So it's not a compromise, it's not the direct middle. It's validating both sides of the perspective and then figuring out what works through some problem solving discussions. So it might be that like if a teen wants to go to a concert on a school night, and we're gonna hold that the artist is really important to that teen. It's an artist that they listen to when they're really distressed to kind of pull them upbeat. It's somebody that contributes to their life worth living. The parent may recognize like, okay, I need to give a little for this, even though it's against my kind of like normal parenting expectations of something to do on a school night. And so they're going to meet them in the middle, and they might problem solve with attending the concert with them to ensure that they're safe, or that there's a hard stop of 11 at the concert. So we're hoping that the act goes on in time, and recognizing we still need some level of sleep hygiene for that night. Our core mindfulness skills also work to increase awareness. We talk about experiencing the world through our 5 senses and reducing our periods of like judgmental thinking or interpreting other people's behaviors or actions, with the idea of really sticking to the facts as we took them in versus the story that we might tell ourselves. And then emotion regulation increases our emotional awareness. So for some of our teens, they come in and their vocabulary around their emotions are generally like happy, mad, sad, anxious, or everything is an upset. And so step 1 of emotion regulation is really starting to expand their emotional vocabulary and the awareness of what's going on internally in response to those emotions. And then also, what are the prompts that we have for some of those emotions as well. And then also other skills to kind of check the facts around a situation. And then the other side to emotion regulation is decreasing our vulnerability to our emotions. So we're really leaning into how do we take care of our bodies to be able to support our day-to-day activities so that we're not tired, we're not hungry. We really talk with the teens about a balanced eating approach, getting enough sleep on a daily basis, taking their medications. And then also some of our life worth living skills come into play here as well. Our distress tolerance skills fall on what we would say is the acceptance side of the work that we do, in addition to our mindfulness skills. And that is really building out their ability to tolerate high levels of distress. So we talk about it with the teens as just being able to make it through a crisis moment without making the situation worse or causing a new problem. And we have a variety of skills that we teach around that. And then also being able to sometimes accept the moment as it is versus kind of digging our heels in, pushing back against something, really looking at what's going to be effective in that moment, and moving forward. And then the last module of skills, our interpersonal effectiveness module, same with emotion regulation, is very change oriented in that we are working with them to increase their skills around being able to advocate for themselves, being able to say no to things, using those skills for conflict resolution, really leaning into their self-respect and their values in specific situations that they're trying to navigate with peers. And then also from there, looking at the relationships that they have. So this kind of really holistic approach that DBT offers for our families can be really beneficial, not only for the team, but also for the parents that participate in multifamily skills group as well. So the next piece, so there are adaptations to the model. So outside of its true form with the 4 modes of treatment, there are also DBT skills only groups that are offered in the community. And those can be really helpful to as an adjunct to traditional outpatient therapy. So looking for skills support around specific things. The key piece is ensuring that that is still an adherent group. So there's like DBT informed spaces, but really making sure that they're doing the correct kind of timeline of skills. And then there are other providers that have developed a DBT parent skills group, which was researched, designed and researched by Jill Rathis from the DBTA team, and then also Dr. Michelle Burke at Stanford. And so that can really help. And there has been evidence to show that even if the teen does not receive any treatment, if the parents start receiving DBT coaching and skills, it actually reduces the adolescent's risk level. They're starting to integrate validation, dialectical thinking, regulating their own emotions in conversations with their teen can really help support the teen in being able to use those skills without even knowing that they're being integrated into their environment. And then some providers do DBT informed care. So they're kind of providing a more eclectic model of treatment where they're integrating a lot of times our crisis skills or some of our emotion regulation skills into their treatment, which can be beneficial and not true adherent treatment. And then the last is DBT for children is definitely, in terms of the number of clinicians trained in this, is on the rise, especially in the Bay Area, and is a really great model for kind of our preteens and young, and like I think it's from like 6 to 11 or 6 to 12 that DBT for children has been researched and effective, and it is kind of the next step down from DBT for adolescents. There's a lot of parent coaching integrated into that, and it can also address those high risk behaviors that we see are showing up in our younger youth as well. So I'm going to talk through kind of what our RISE intensive outpatient program looks like, and then also share some of our success factors as well. So we are a comprehensive dialectical behavioral program embedded into an IOP model. So the teens are with us 4 days a week for 3 hours a day. And we work with teens that have engaged in some sort of suicidal behavior or non-suicidal self-injury and like over a chronic long-term period of time from 8th grade through seniors in high school. And we are also a collaborative program, as I mentioned, with between Children's Health Council and Stanford Children's Health, and really work to kind of build out and address this high need for a suicide treatment in the Mid-Peninsula. We're also the only comprehensive DBT program at an IOP level of care in Northern California. There are other programs that do DBT informed care, so they don't offer the phone coaching as a core component, but that is something that we do for our teens. And because of that phone coaching, we are able to hold teens who might traditionally be referred to a partial hospitalization program. And given the commitment component and how closely we work with the parents, sometimes we're able to hold them at an IOP level of care. So they're still able to go to school for part of the day before coming to treatment. So for our IOP, and some of these are in line with like DBT treatment criteria. So our primary targets are self-injurious and suicidal behaviors. So all of our teens have engaged in some level of that, either preparatory action or like kind of aborting an attempt before it happens. We do have teens who are coming to us after an attempt, either after a hospitalization or that they've disclosed an attempt to their outpatient providers or their pediatricians at a checkup, and they're able to be referred over to us. We also work with teens who have kind of primary diagnoses of depression, anxiety, stabilized bipolar disorder, and trauma that are consistently impacting their quality of life. Some of our teens are only able to tolerate small periods of time at school. And so our goal is to really build that up. The other piece is having frequent periods of emotion dysregulation, where we see kind of that spike in emotion vulnerability and sensitivity. They have a hard time maintaining effective relationships with family, with friends, with school staff. We also work with teens who have mild substance use. Because it's a behavior, DBT is really effective at targeting that in the work that we do. And a lot of our skills really benefit our teens who engage in substance use as a coping strategy. And we also work with teens who have multiple hospitalizations or visits to the ER or the ED for crisis stabilizations. In terms of what RISE and DBT in and of itself is not effective for, is any active psychosis. We work with teens who definitely have mood dependent psychosis that's being addressed through medication management. Lower functioning autism spectrum disorder diagnoses, because it's a milieu-based program and there isn't as much evidence for DBT in supporting our autistic youth. We really want to ensure that we are the right fit, and sometimes we are not. And then if they have an active medically unstable eating disorder, that's for us, that's a higher priority in terms of getting targeted eating disorder treatment. And then moderate to severe substance use. And then any significant behavioral issues, because the expectation is that the parents work really closely in terms of safety monitoring and skill support. If there's any tension in the household, sometimes that can be really difficult to navigate. So this is just kind of what our program looks like. So we take the 6-month curriculum and condense it down into 9 weeks. So they get 2 individual therapy sessions per week, 2 multifamily skills groups. We've also integrated a DBT parent coaching group for our families into RISE. And then they have the 24-hour phone coaching. Our goals are really to reduce and eliminate suicidal and self-harming behaviors, increase their ability to tolerate and regulate high distress and their emotions, improving their relationship, reducing the need for higher levels of care. We're really able to hold teens in the program that might kind of experience this high suicidal crisis while they're with us through the use of phone coaching and our joint kind of supervision plans that we have with our parents. This not only reduces like hospitalization and possible contagion or other impacts that hospitalization can have, but it also teaches the teen that they can get through those really high crisis moments without needing additional support, and then helping the teen build that life worth living. So this is what their kind of daily schedule with us looks like. And in terms of, we have an occupational therapist on site that runs our mindful movement group. Our expressive arts group is led by an art therapist who's also intensively trained in DBT. They get additional skills practice on our Monday and Wednesday groups, where we're teaching skills outside of the rotation. They have their life worth living group. And then applied skills is modeled after our consultation team. So it's a space where the teens are able to bring a problem they're trying to solve to the other teens in program to get feedback and support and validation, which is really a space for our teens that can be really helpful. So within RISE, we operate with full fidelity to the DBT model. We also have Dr. Michelle Burke from Stanford on our team to kind of ensure that we are providing adherent DBT. And all of our licensed clinicians and our trainees are intensively trained in DBT. Our predoctoral and postdoctoral interns and our CAP1 fellows all participate in a DBT seminar on a weekly basis, which I co-lead. And then we are continuously doing additional training in working with complex high-risk adolescents. So I have DBT training specific to substance use and disordered eating. So we are, because of the model that we have and how closely we work with our families, we have a pretty high graduation rate for our teens. It's about 74%. Our teens move through the 9-week program. Sometimes we're able to extend them if they need a little bit more time in program or they need support in stepping down. We really work closely with both the team because they drive the treatment and their families in order to ensure that we're able to support them and prepare them for stepping back from essentially 12 and a half hours of treatment per week into their day-to-day. And then we are constantly kind of looking at our program to ensure that we are meeting the needs of our clients and then also improving. So in
Hi, I think Jennifer, you might be frozen for me.
For me as well.
Yeah, for me as well. So, um,
Oh no, I think she had to hop off. Maybe she's gonna rejoin.
yeah, I think she was close to the end of her.
Presentation, yeah.
There she
Oh,
is. Welcome back, Jennifer.
sorry, my Wi-Fi has been all over the place today. So let me share my screen. Almost there. So the parent coaching group is integrated into our program now. And so the families receive 6 weeks of direct parent coaching around navigating suicidal crises with their teens and also to reestablish their relationship. Given that for a lot of our families, when they come to us, there's a lot of tension between parents and teens given the supervision requirements or hospitalizations. And so it's really about rebuilding and repairing that relationship as well. And then these are just a few of the testimonials from our families. We hear from our teens. Sometimes they stay at the Children's Health Council with us for outpatient therapy or psychiatry. And so we get updates quite often from our families after they leave us. And for most of our teens, they're able to navigate. They still have those moments of suicidal crisis, but they have the skills now to be able to manage them without moving towards a behavior. They know their warning signs. They're really able to step in and integrate the skills. For some of our teens, they do step down and do a comprehensive DBT outpatient program, which extends their DBT treatment another 6 months, or they step into the skills group that we offer. One of the other pieces I think that leads into our next speaker is within RISE, psychiatry is integrated into the program. And we work really, really closely with our psychiatry team to support our families. So they have this kind of whole level of support in program while they're with us and really navigating what is a medication target, what is a treatment target, where do they kind of meet in the middle in that space. All right. Thank you.
Thank you very much, Jennifer. I'm so glad that you were able to come back and finish.
Yeah.
But it is obvious that you have worked really hard with the team in building a comprehensive DBT program that meets the needs of children and families, which is just so hard to find. And I think having the participants in the call in the Zoom really understand what's different about that
Mhm.
kind of a DBT program is really important. So thank you so much for sharing. Um,
Yeah. Thank you.
okay, so Sana, if you could put up the next slide. Okay, so our next speaker is Dr. Petra Steinbuckle, who is the Director of Child and Adolescent Psychiatry at UCSF Benioff Children's Hospital, Oakland, and Director of the Child and Adolescent Mental Health Access Portal, known as CalMAP. And as you might imagine, she's a child and adolescent psychiatrist and a professor of psychiatry at UCSF School of Medicine. And she's going to be helping us understand what is the role of medication in youth suicide prevention. Um, uh, Dr. Steinbuckle, take it away.
Thank you so much. It's really great to be here. And I've got a couple of different audios going on. I'm going to change that up. Okay. So I love seeing all of hearing all of the presentations so far. And I think this is just such a wonderful integration of some really high risk, areas, and also really wonderful interventions, including the non-clinical supports and ways of thinking about, where folks can go outside of just a straight medical intervention, and also really, really love and appreciate DBT. So it's great to be among so many talented colleagues. I am going to share. And so we'll be talking about, what is the role of medication in youth suicide? And this is a complex topic, and I think we'll kind of scratch the surface, but my hope is that, we'll be conceptualizing and taking away that this is not just a binary, do I prescribe or not, but more so thinking about, the whole person, the context, the whole family. And so these are the three objectives. What are the three, or if you can name three considerations regarding medication when you're assessing youth suicidality, and then one significant intervention, and then a little bit about the risks and benefits of common medications that are used to treat conditions associated with suicidality. So this is my colleague, Dr. Michelle Reeder, who's a child psychiatrist. And this consult actually came to me a couple of years ago from a really very driven and passionate pediatrician who was working with a 14-year-old that she had known for a couple of years, whose PHQ-9 score, depression screening score, was 19, which is really elevated. And the question was, do I start medication? And then in asking a little bit more about the history during our phone conversation, the young person had been isolating more, had been kind of more withdrawn, staying more at their room and not doing as well in school, and then not really wanting to engage in usual activities and sources of identity. And here's the PHQ-9, which is, one of the main screening tools for depression, and is endorsed by AP as a way of assessing youth depression. That said, this has been used for a long time, it's validated. And I do want to point out that, this question number 9, have you had thoughts that you would be better off dead or of hurting yourself in some way? It's not the most specific way of asking about suicide. The ASQ that was referenced earlier was, is more focused on the specifics of, have you been thinking about this, and helping assess that continuum. And so there is really a strong encouragement to take a deeper dive and find out what's going on. So you have the score, what do you do with it? And, just like with abdominal pain as a chief complaint, this is really hard to read right here, this image, but basically it's a really deep dive on a differential diagnosis that we're used to thinking about in medicine, of like, what are the possible causes of stomach ache? And this is a very, very long list of possible reasons. So just the way that you would investigate further in terms of assessing what's going on here, and how acute is this, how severe is this, what do I need to do right now? I want to invite you to look below the surface. And with this particular young person, it turns out that they identified as transgender, and had been born biologically female, and then had started to have more feelings of identifying as male, and had shared this with his mother, but not with his father. Has been engaged in some cutting, some self-injurious behavior, which is different than suicidal intent, with the intent to die. However, there's a much higher risk of dying by suicide or making a suicide attempt in youth who engage in self-injury. So I want to distinguish those two things. And this was a family who had immigrated from Mexico, and the parents did not have legal citizenship, and the father worked super hard and was not as available, but really didn't believe in mental health anything, and didn't believe in depression. And therefore, there had been no discussion about this young person being transgender. And so in terms of a medication, I've certainly had young people that I've worked with for a number of years, and then over time, it's come out that they, feel like they are transgender, and then, as they proceed along their gender journey, they end up not needing the SSRI medication that they had been taking for depression. So I just want to call out that we always need to look at, what we see on the surface in terms of behaviors, and the PHQ-9 really gets at, some behaviors, and then also some subjective feelings. But what we see on the surface doesn't tell the full picture. It's the 10% tip of the iceberg that's visible above water. And want to really highlight, what are the feelings, what are your thoughts, your beliefs about yourself. And this includes, not only basic beliefs, but also your identity, your self-esteem. And then I also want to highlight the perceptions and physical sensations. As we've heard today, in particular, persons with sensory sensitivities really may be completely overwhelmed in an environment that is completely unfriendly to their sensory needs. So what else is going on below the surface? Also want to highlight that suicidality is on a continuum, and this is what the ASQ really tries to get at when going through the questionnaire, or another questionnaire that's used sometimes is the Columbia. Basically, that you can be fairly okay, or that you, for example, have, thoughts of wanting to die, or had a thought about that a year ago, which one of my teen patients who was seen in the emergency room, had endorsed on the ASQ, yes, I felt that way, a year ago. And then that resulted in a whole entire, suicide assessment and comprehensive evaluation, when maybe it wasn't necessarily warranted, to then along this pathway, having more thoughts with a plan, but without the intention. And then, here at the far end of the continuum, making a suicide attempt with access to lethal means. And we'll come back to that in a little bit. Here are some just examples of presentations. Again, this behavioral reinforcement, thinking about what happens when someone is sensitive and that has that biological vulnerability, whether that's emotionally really sensitive or from a sensory input perspective, really sensitive. And then when there is a significant reaction to this, then it becomes inadvertently reinforcing, albeit with the best of intentions. And and then the idea that, you can have thoughts that come and go, but the importance is to know what's happening right now, what's happened in the past few days, and then looking at really important risk factors. There are a number of psychiatric conditions that are associated with higher rates of suicidal thinking. There are kind of fixed risk factors that include a family history of dying by suicide or of multiple suicide attempts. And that's something that can't be modified, right? Other ones are previous suicide attempts personally, a history of substance use, especially when there's current active use. Again, thinking about that disinhibition and that substances often can make someone be more disinhibited and more likely to act on feelings. Plus, it sets up a kind of an ongoing cycle. For example, with drinking, you may feel good in the moment, but then feel terrible the next day. And that can really perpetuate depression. Having this physical disability, illness, long-term pain, these are things that, to some extent can be modifiable, but are not as modifiable. However, we need to focus on the things that are actually modifiable. For example, exposure to bullying is a big risk factor. And with support, with help, with understanding what's going on, that is something that can be modified. Ideally, getting support for a mental health condition is something that is modifiable. And then, of course, access to harmful means. So when you're looking at suicide assessment, you want to think about this old mnemonic, old card. So what's the onset, location, duration? What are the characteristics? What is aggravating about it? What is potentially relieving? And then the timing and the severity and persistence. And if there have been any past attempts, what are the most severe and what's the plan used? I also want to underscore that it's more about someone's intention to die. So, if someone says, I took 2 ibuprofen, and, I just wanted to get rid of my headache and maybe fall asleep, that's different than I took 2 ibuprofen and not understanding that that is not a lethal amount of ibuprofen, but if it was with the intention to die, that is a suicide attempt. So it's more about how someone is understanding this and thinking about it that helps the severity of their intention. It's also really important to think about culture and cultural factors and how does this impact screening, assessment, treatment planning. In our program, CalMAP, we really try to underscore the idea of cultural humility and cultural curiosity rather than cultural competence, which is kind of a longer standing term because none of us can be competent in cultures that are not our own, or sometimes even in our own culture, right? So I think it's, adopting this approach of being curious, asking questions and not assuming that you know the answer. And with that also de-emphasizing kind of the potentially relational part of this, because a lot of people, when they talk about screening, they seem to feel, concerned, oh, it's going to, negatively impact my relationship with this youth. Instead, if you can phrase it as, the screening is universal. This is something that we do for everyone. It's not that any particular group or individual is being called out in this. And then also with the ultimate goal of my job is number one, to, help you stay safe. And then with that, we can together proceed on this journey to getting you healthy. Here are some protective factors, and this is always super important to consider as well. And then, when some of these things are being disrupted, like the young person I was talking about earlier, are you still close with caring friends or other adults? And what are your connections to these things like school, and then access to health services also. And that, you know, you can kind of try to stratify according to these different parts of the equation that add up to whether someone is more low risk, moderate, or higher risk. As has been stated already, suicide attempts happen most often within 10 minutes of a thought about suicide. And so the key is not to prescribe a medication in that moment, but to partner with the individual and ideally with caregivers, anyone who's around, to restrict access to lethal means. Again, and just saying this is the standard for doing this. You know, we've heard different aspects of how do you talk to, you know, caring loved ones. And I think it's really important to underscore that a young person generally has people around them, and you may not need to disclose or go into anything related to being transgender or, you know, anything else like that, but more so helping the young person be able to share with the folks that they're living with, here's what's going on and how can we help keep you safe. And also embed some of the principles of dialectical behavioral therapy that were just described, that you don't want to overblow or kind of inadvertently reinforce, you know, this kind of presentation. I am mindful of time, and so I'm gonna just, you know, go through these a little bit more quickly because we want to get to the medication part. Mental health conditions and concerns are one aspect of, you know, someone feeling suicidal or wanting to make a suicide attempt, but it's not the only driving force. It can be because of, you know, profound grief in the moment, a breakup, losing someone that you love. So it doesn't have to be that someone has a diagnosable mental health condition, but these are ones that have higher risk of suicide attempts and completed death by suicide. So I want to point out, you know, the ones that have already been mentioned, and then also call out eating disorders specifically, and substance use as having significantly higher risk. And then, you know, we do always think about depression and anxiety as having high risk, but ADHD, especially in young people, it is a higher risk factor than depression for kids under 10 and younger who make suicide attempts because of that impulsivity. And this is just a brief review of, you know, some major studies on depression. And the key takeaway generally is that combined, you know, medication plus therapy is better than either of these alone, and better than placebo. And the Tordia study showed a little bit more nuance of this, that having cognitive behavioral therapy and developing those skills is really key. And that predictors of a more positive outcome were if they responded to CBT, if they responded earlier to a medication, and then other ones predicted a more negative outcome, including substance use, worse symptoms, especially anhedonia, lack of enjoyment, and then family conflict. And this is, so I think folks are probably familiar with the black box warning that came out with the FDA in the early 2000s. And basically, when Prozac was first put out there in the early 1990s and kind of through the early 2000s, rates of suicide had decreased in young persons. And then after this black box warning came out, in particular, pediatricians and primary care providers understandably felt less comfortable prescribing these medications. And since then, and this analysis in 2022 looked at other factors that, you know, have thought to contribute, including more social isolation, use of screens, et cetera, that even when pulling away those additional factors that may contribute to now higher and increasing rates of youth suicidality, that basically the 30 days before starting an SSRI, is associated with a higher risk of suicidal ideation. And then even in, the brief period after treatment, starting treatment, that those times are associated with a decreased risk compared with the 30 days before. So this tries to demonstrate, what's been described for a long time, basically that, we've seen this relationship that we haven't been able to say is causal, but more temporal, that that since the suicide risk warning came out and lower prescription rates, that that suicide has gone up. And this just further underscores this, and I think everybody's going to be getting the slides. How to talk with parents about this. So this is something that a lot of people, when you Google it, this is one of the first things that comes up. And basically, when I talk to parents about this, this is what I describe. And basically that depression is definitely worth treating. And the point of the medication is to help you feel better and not worse. And if you do notice anything getting worse, then I want you to reach out right away, not wait till the next appointment. I would much rather hear from you than not. And to frame it in that way. And also to talk about the first 9 days of treatment are when anything that might be related to medication and increased suicidal thinking is most likely to occur. This is the breakdown of the FDA warning that the FDA had reviewed 24 studies and found that there was an increased risk of suicidal ideation and or self-injurious behavior from 3.8% of patients receiving SSRIs versus 2.2% on placebo. So it's still a very nominal difference. However, there was no actual increase in death by suicide in any of these studies. And the highest risk tends to be in those first 9 days. And so this is thought to be in part related to something called activation, where, the younger the child, the more vulnerable they may be to feeling a little bit more activated. And it's generally in these domains, so feeling more irritable. Akathisia is a really telltale sign. So somebody who is like moving around a lot, tapping their foot and leg in ways that they never did before, being more loose, disinhibited, and looking potentially a little bit manic, and then engaging in self-harm is a sign of activation. And this can be treated first with decreasing the dose, or if it's found to be really effective, you can add in a beta blocker and continue the medication, or you can try a different SSRI. And this is different than bipolar switching, which usually occurs later on in treatment, and is something that tends to happen more with older teens. And it's much less common than activation. And so it's important to understand that and acknowledge and look for the differences. Behavioral activation tends to happen early on within the first 3 months, typically, or when there's been a big dose increase. Other medications associated with increased risk of suicidal thinking include anti-epileptic medications. And this is a really nominal amount of increase. I think, anytime you're starting a new medication, I like to just say, if you're noticing anything that you don't like, if it's going in the wrong direction, please let me know, because the list of potential side effects is long. And meanwhile, the risks of not treating can also be significant. So we can talk through whatever you might be experiencing. And some of those things can be like the, GI upset that you get with SSRIs, and that's usually temporary. And there are ways that you can mitigate against that. For example, making sure that people take it with food versus some of the other things like activation. You may not be able to change that. Atomoxetine is another medication. It's kind of a second line ADHD medication. And and it can be really, really effective for some people. There is thought to be a slightly increased risk of suicidal thinking with atomoxetine compared with placebo. And it's more of a binary thing. It's either you experience it or you don't. And so I think that's just something to look out for when you're first starting atomoxetine. Similarly, with multiple sleep aid medications, which usually are not prescribed as much in young people, but in particular the Z drugs, so Ambien, et cetera, and then also benzodiazepines and trazodone have been associated with a higher risk of suicidal thinking and behavior. Just a little bit about our program, in case you haven't heard of us. So CalMAP is a consultation to primary care program that offers resources. We have a lot of resources around suicidal ideation on our website. And then we also have a number of training opportunities that include a lot of virtual trainings, and we have recordings of our different webinars and shorter recordings from our Project Echo didactic. Those tend to be about 15 or 20 minutes, where you can view highlights of different aspects of suicide assessment in primary care. And then if you haven't registered with us yet as a PCP, please do so. We are at calmap.org, and you can also start consulting with us. We're not a crisis support system, but we can help PCPs think through if you do an ASQ in your office, or if you're doing a PHQ-9 and you're wondering about how to interpret the scores. We're more than happy to kind of talk through how to think about it and how to proceed. In terms of key takeaways, I hope that we all take away that, suicidal thinking is on a continuum, and there are no medications to treat suicidality. However, using medications to treat conditions that are associated and or changing things in the environment, including sometimes, just changing the sensory inputs for somebody can go such a long way, or mitigating, bullying. The restriction of lethal means is absolutely essential and is the most important thing that you can immediately change in the moment. And then having that kind of looking below the surface thinking whenever you're assessing around this, and taking kind of the long view, and also the messaging, I want to help keep you safe. Let's see what we can do together to support that.
Thank you very much, Dr. Steinbuckle. That was really an excellent way of thinking about whether medication was appropriate or not in a given situation. And having the resource of CalMap is also really important to assist healthcare providers in knowing kind of what to do next or how to think about it. So thank you so much. Our next speakers are going to be telling us about additional resources. Dr. Laura Tully is going to be talking about Soluna, which is a relatively new resource in California as part of the Cal Hope program. And Camilla and Darcy are going to be talking about Never a Bother, which is part of California's Department of Public Health's Youth Suicide Prevention Campaign. So these are resources for your patients, and it's really important for you to know what they offer and to be able to use it to support your youth, particularly on a prevention side. So this is really something they're going to be talking about at length. So, Dr. Tully, I think you're going to.
Yes, thank you, and good morning, everyone. Thank you for joining us on your Saturday. I'm going to share my screen and tell you a little bit about Soluna. Some of you may have heard of Soluna already. This will be a nice refresher, and I'm here to answer questions as well. And for some of you, this may be new. So I know already this morning, you've been learning about how to spot suicide risk, about what to do, how to talk about it. And what I want to do is make sure that you are aware that Soluna is a tool that you have in your toolbox to add into the treatment plan to support the young people that you're seeing. Soluna is a CalHOPE program, so it's funded through the California's Children Youth Behavioral Health Initiative, just like CalMAP is. And it is a prevention and early intervention tool that is accessed digitally. And I'll talk a little bit about that. So as I said, it's early intervention and prevention. So what we do is we deliver early intervention and responsive support at a population-wide scale. So we are statewide. We are for everyone that falls in the age range, with a focus on prevention rather than cure. And we understand from the research that youth suicide prevention starts from giving young people access to resources before they need them, before crisis hits. How do we give them the tools, the skills, the support, so that when life does throw the inevitable stressor at them, they're better tooled up to do it? And that's what Soluna is designed to do. So we reach youth where they are in education, healthcare, social media, other online spaces. And we provide early and responsive self-help, peer support, and professional support. This includes self-guided resources and coping tools, peer support from other young people like themselves, and professional support from our behavioral health coaches. And we also offer a digital front door, so to speak, into other healthcare services. So if young people need access to additional resources in their community, additional healthcare or behavioral healthcare, we're able to connect them. And of course, if crisis does strike and they need additional crisis support, we are able to connect them to that as well. So in that model, that prevention and early intervention model, Soluna provides free mental health support to all 13 to 25-year-olds in California via smartphone, tablet, or web. It is available in English and in Spanish. And Soluna includes, as I have mentioned, self-guided resources and coping tools. So think things like breathing exercises, journaling, mood logging, etc. A peer support community forum, and I'll talk a little bit about how we keep young people safe in that forum, and one-to-one coaching with behavioral health professionals. As you can see here, that our one-to-one behavioral health coaching is available from 10 a.m. to 9 p.m. And just a little note here, 9 p.m. is the last entry time. Your coaching session can go all the way through to 10 p.m. And the coaching can happen via in-app chat, so just kind of as if you're having a texting conversation with the coach, but also by video appointment or by phone. As I mentioned, the whole platform is available in English and in Spanish, and then we have phone coaching available in the additional 17 Medi-Cal threshold languages. This is just a glimpse of what the platform looks like if you're accessing it on a smartphone or a tablet. And as I said, we've got self-support, peer support, our professional support through coaching, and then this community resources. And I'm going to give you a little bit more detail about these now. So the first thing I want to tell you about is who our coaches are. They are certified mental health professionals. There's 3 primary groups that we have in our coaching team. The majority of our coaches are certified peer support specialists. So these are individuals who bring lived experience of mental health recovery or other social challenges, and they've gone through a special certification coaching process to learn how to integrate that lived experience into their mental health coaching. And they've been certified primarily through a California group called CalMesa, CalMHSA, and they are the statewide group that do the regulation of certified peer support specialists, and some of them have national certifications as well. We also have our sort of general mental health support professionals. These are coaches who may or may not have lived experience of mental health recovery, but they're not necessarily using that as part of their model. These are experienced practitioners. Most of them have masters or higher level degrees in a mental health field, along with certifications for mental health support. And then finally, we have a small team of substance use disorder counselors. These are individuals who are specially trained and certified in supporting youth with substance use challenges. And all 3 of these groups of coaches are supervised by licensed clinical professionals, ranging from LMFTs to our licensed clinical social workers, licensed counselors, licensed psychologists, etc. And they provide all the training and supervision and safeguarding support. So they do all the things that licensed people do in behavioral healthcare. They're supporting the direct service from a supervision and training perspective. What do our coaches do? Well, they moderate posts and safeguard journal entries to ensure safety. And I'm going to talk about that moderation in a second. And they host drop-in chats and scheduled sessions. So service users are able to drop in and talk to a coach. Right now, our wait time, it varies anywhere from just a couple of minutes up to kind of 20 minutes. So it's pretty instant. Like, you are a young person, you're dysregulated, you need support right now. You drop into Soluna and you're talking with a mental health professional very, very quickly. You can also schedule a chat with a preferred coach, and we can guarantee being matched with your preferred coach within 3 business days. Here's just a list of some of our qualifications that our folks are required to meet before they join the team. And of course, they get continuing education throughout their work. So I promised I'd talk about safety. It's a top priority for us. You know, we are treating our most vulnerable youth and supporting them on the platform. And we want to make sure that this is a safe and vetted space for them. So I talked a little bit about our peer community forum. And it is a place where service users can post questions and answer other service users' questions. So I want you to think of it a bit like a safe Reddit. So it's sort of structured that way, in that you've got a service user post something, and then you can either like it or respond to it, and you can sort of see these threads. And the way we keep it safe is all of those user-generated posts or content is pre-moderated before it goes live on the platform. So unlike on the regular internet, where it's moderated in real time, so think about, you know, you post something to Facebook or Reddit or Instagram, and then moderators review it and they'll flag it and have you take it down if it violates community guidelines. Which is great, but you can't undo the harm of people who've already seen it. What we do is we review those posts before they go live. So everything is evaluated against community guidelines to make sure there's no hate speech, trolling, inappropriate content, bullying, etc. And also to make sure that that young person hasn't unintentionally identified themselves. So it's all pre-moderated. There's no chance for young people to see something that is inappropriate or unsafe. We also have an anonymous model, so the service users are anonymous to each other, and there's no way for them to find out who each other are. And as I said, we make sure that they're not unintentionally revealing who they are in their posts. We have robust safeguarding policies for risk management. So we do get risk flags for young people who are experiencing suicidal ideation. And what we do is we do gold standard risk assessments, very similar to what you heard about before, such as the Columbia, where we evaluate risk level, and then we have clear protocols for that risk level. No matter what the risk level is, everybody creates a safety plan, which they can do with their coach. And finally, our service users cannot directly message each other. So there's no way for them to have kind of private conversations and create unsafe relationships. The only way they're interacting is in that pre-moderated space. And as I mentioned, we have a wellness and safety plan feature that they can create with their coaches. This is a very gold standard evidence-based safety plan intervention that, you know, talks about coping skills I can do on my own, people who can distract me, trusted adults in my network that I can confide in, my professional network who can keep me safe, and all the contact details for my local crisis supports. Finally, we have our care navigation. So this is that digital front door that I talked about. It's a concierge service that connects youth to local support. So we have a team of trained care coordinators who ensure young people receive the care that they need from an extensive database of carefully curated resources and vetted affiliate partners. And it is a whole person approach to address social determinants of health. So we're not just referring them to healthcare services, we're connecting them to other community resources like housing, financial, etc. Here is a snapshot of the partners that we're already working with in our Care Navigation affiliate network, and it's growing every day. And I just want to take one extra minute to tell you, okay, now you know what Soluna is, how can you use it in your practice? And here are 3 spaces that I recommend using it with the young people that you're working with. Pre-appointment support. So if you've got a young person coming in and they have to wait, you know, a week or so to see you, but you know that this is something you're going to be discussing, they can schedule a coaching session while they're on a wait list, or just kind of, you know, explore the tools. You can have in between session support. So if you've done a PHQ-9 and you're doing some treatment and you're going to have this kid come back in a few weeks as a checkup, can they use Soluna as their support tool in between? And then discharge planning or booster support. So if you are discharging them from a particular treatment program, or you're connecting them with another treatment program, Soluna can be that part of that discharge toolbox that young person gets. Flashing up just a little bit of data for you. We launched in January 2024, and we've reached underserved California youth and increased access to mental health supports. 49% of our coaching sessions are happening outside of 9 to 5, which just shows the importance of having resources in the evenings. 1 in 3 of our users tell us that if Soluna didn't exist, they wouldn't have access to mental health support at all because of other barriers. 50% tell us that this is their first time accessing support. And here are some stats around those underserved communities. So 57% from under-resourced, 56 identifying as Black, Indigenous, or member of a community of color, and 44 identifying as Latinx or Hispanic. And our service users love coaching. Nearly 100% of them are saying, this is great, this is working for me. You've got the slides. Here's some testimonials. Just in this last minute, I encourage you to follow us on Instagram. If you're on TikTok, follow us there. If you want to follow us from a provider perspective or a business perspective, I really encourage you following us from LinkedIn. The Instagram is more user focused. The LinkedIn is more provider focused. Both are great places to learn what we've been doing. Thank you. Together we can change lives. Let's give our young people this tool early on so that they can stay safe. And if you want more information about the impact, head to solunaapp.com/impact. Thank you.
Thank you so much, Dr. Tully. My name is Darcy Pickens. Thank you so much for hanging with us this afternoon. I know it's been a lot of information to absorb this afternoon. My name is Darcy Pickens, and I am with the California Department of Public Health's Office of Suicide Prevention. I'm here today with my colleague, Camelia Mortazazadeh with Civilian, our media and communications partner. And we're going to share a little bit more about our state youth suicide prevention campaign, Never a Bother. Like CalMAP and Soluna, Never a Bother is also funded by CYBHI, the Children and Youth Behavioral Health Initiative. Next slide, please. Just a quick reminder, even for those of us who work in this space every day, this can be a heavy and delicate topic. So I think a colleague of mine said it really well the other day. Helpers are not always the best at asking for help. So just a friendly reminder to reach out for help if you need it and to make yourself a priority. Next slide, please. You have all of these slides, but again, just kind of encouraging you, like others have, to follow us on social media and check out our main resource, which is neverabother.org. And you'll see more about that in just a moment. Next slide, please. And one more. Next slide. Thank you. Oh, sorry. There was a delay on my end. Okay, so Never a Bother is intended to support you through age 25 and their adult allies. So that's parents, caregivers, coaches, folks like yourselves who are in a position to provide support. And our goals really come down to increasing knowledge and awareness of suicide warning signs and sources of support. So we talk about resources like Soluna and some of the other things that you've heard about today, the Trevor Project. And then increased self-efficacy and belief that increased self-efficacy and belief among youth that their feelings matter and that they're worthy of support. And you'll hear more about where that comes from in a moment. And then ultimately increased help-seeking behavior. Next slide, please. A unique and really wonderful thing about this campaign is that it has been grounded in co-creation. We've worked with youth from the ground up on every aspect of the campaign. Our structure includes media and communications efforts, and then also local programming through our grantee network, and youth are involved in the planning, development, implementation of every aspect of the work. So you will see that shine through. Next slide, please. Little bit about our research and strategy. Thank you. As I mentioned, the campaign has been co-created. So one key element of that is our youth advisory board. They represent members of some of our most impacted youth audiences. They're paid for their time, they receive training, they're spokespeople, and really have been integral to the success of this campaign. So always want to give them some kudos. Next slide, please. In total, we've worked with over 400 youth in the development of this campaign. This slide shows you just a portion of that. And again, everything from concept development, testing, and then actual co-creation of media assets, which is ongoing. Next slide, please. You heard Peggy and a few others reference this today as well. So what we heard throughout that formative research portion was the need for validation, trust, and safety among youth. This is what we heard consistently with all of the youth that we spoke to, and really heavily informed our campaign strategy. Next slide. And you can see here kind of more of a deep dive into that strategy. I'm not going to go over this in detail, but do want to just kind of point out that top portion is really what we heard during our formative research from youth. And then all of that is informed by that bottom row, safe and effective messaging guidelines, making sure we continue with co-creation, and then suicide prevention and crisis model best practices woven throughout all of our resources. And now I will hand it over to Camelia.
Thanks so much, Darcy. Hi, everyone. I'm Camelia Mortazazadeh. I oversee strategy and research at Civilian. We're very fortunate to be able to work on this campaign, and I'm going to give you just a very high-level overview of what this campaign entails and what resources are available for you. I will definitely put our email in the chat. We have made toolkits with resources for providers, for schools. Many of them have been sent out, I think, to all 58 county offices of education. So if you see these things and are interested and would love to have some in your practice, please let us know. Real quick, the overview of the campaign, this looks very different than probably some past suicide prevention campaigns you've seen. It's very bright, it's colorful, there's retro-inspired imagery. The language is very positive and uplifting. And as Darcy mentioned, this is a lot of what we heard from young people. Images of people can oftentimes be very polarizing if you don't identify with the person in the picture. And so our characters they have talk bubbles that really talk about things and emotions people are feeling, but probably don't want to voice. And it's just a very uplifting campaign with this overarching message that you are never a bother, and a call to action to parents, caregivers, and supportive adults to let young people know that they are never a bother, and also a peer message too. Our website is designed to be mobile friendly. It's actually gotten a couple awards. Very simple. You can get all the information you need within 2 clicks. And it very much breaks down almost exactly what we heard from young people. How can I help myself? How can I help my friend? And if I'm an adult or a caregiver, how can I help a young person in my care? And very much geared towards answering those questions, the things that are top of mind. We do talk a lot about as well, some of the resources you heard earlier. Obviously 988 Saluna is there, Bright Life Kids is there too. But one thing we heard a lot from young people is just this need to really break down what happens when you call 988. We know that young people are more likely to tell their friend if they are feeling suicidal, but also we worked with so many youth and they expressed so much fear, trepidation, mistrust of these resources. So we made some tools and resources. They're on our socials. Our campaign is very heavy social because that's a lot of places where young people are. But just things like really breaking down the before, during, and after. I'll give you just a quick snippet of one of our animation videos that talk about that.
You'll hear a recording. You've reached the 988 Suicide and Crisis Lifeline. Then you will hear some options. If you select 1, 2, or 3, your call is routed to the most relevant national crisis network, such as the Trevor Project Lifeline. If you stay on the line or press 0, your call gets routed to a 988 Lifeline center based on your area code. The average wait time is less than 1 minute. A professional or a volunteer will answer and ask you some questions. Answering these questions is 100% optional. You don't need to provide any personal information to receive support. They'll ask if you're having thoughts of suicide and how they can support you or help you support a friend. And then they'll listen. They'll provide support and share resources. The goal is for you to feel heard, understood, and help you stay safe. Most people who reach out to 988 are helped during the call without involvement of emergency services. And studies have shown that most people feel less overwhelmed by thoughts of suicide and more hopeful afterwards. Always remember, you are never a bother.
And that's just one example. For the sake of time, I won't show you all the commercial, but I'll happy to send the link. But I think just to get to what we talked about in the research and strategy, it's really key for us to share different resources, whether that is 988, whether that is Teen Line, Saluna, letting young people know that you can text, you can call. There's lots of ways to get those support services in real time and just giving them that option. So what are some of the resources? I believe many of these are sent to you. One of the things, we have a lot of tip sheets for community-based organizations, schools, and partners, things like making never a bother spaces. And we have materials to help you sort of make these affirming spaces where young people can talk about mental health. A lot of work with our partners. They've even done things like never a bother Wednesdays, or different days that are intended to have space for young people to talk. We have posters, we have lots of resources. We've made lots of resources for the Two-Spirit LGBTQI community in respect of Pride Month, but much more to come. Our campaign, as I mentioned, is very heavy social. One thing that's been really useful is we have these palm cards, and as you can see, again, very visual, heavy, and fun to really look at, but things that kind of really break down coping skills, getting help, how to help a friend, or how to help your child. And again, a lot of the messaging can go to multiple audiences. We launched our campaign officially in April 2024, and then we launched a caregiver and parent component last September. We've had lots of media in the market, billboards, commercials and ads, but also, as I mentioned, our campaign materials. Here's some examples of some of our posters. We made affirmation cards for parents and caregivers to let them know, and then just really creating resources that speak directly to some of the questions we heard parents and caregivers tell us. Does talking about suicide put the thought in my child's head? What are the things I could do? How do I start the conversation? How do I ask directly? So a lot of things that really help facilitate that conversation and are helpful for parents, providers, and just other adults in young people's lives. And as I mentioned before, we have great tip sheets and ways that organizations can get involved and use our campaign materials. And as I mentioned earlier, if you are interested in receiving a hard copy of a toolkit, we're happy to ship that to you. You can get those there usually within a week. Please just reach out. I will put here's our social channels, but info@neverabother.org, and we can get those to you fairly quickly. And we just want to get these materials out in the world. And that is all we have. Thank you.
Well, thank you so much for sharing all these resources. I know that you all have spent a lot of time and energy in developing things that are user-friendly, that can be widely disseminated, that are targeted toward this important topic, but especially to supporting youth and their families and their friends in dealing with mental health issues that don't necessarily come to the attention of their healthcare providers, but that need to be disseminated widely in the community so that people know how they can get help when they need it. So thank you so much. We have a few minutes for questions before we wrap up, and I think there's been in the chat a lot of back and forth with Dr. Steinbuckle about SSRIs, how to assess for whether SSRIs are an appropriate intervention for depression or anxiety, and what the contraindications are, and whether there are better approaches for anxiety or depression than SSRIs if medication is being considered. So perhaps we can let Dr. Steinbuckle expand a little bit for the all of the audience about her approach in this regard. Are you there, Dr. Steinbuckle?
Um, it's Wi-Fi. Do you mind repeating the question?
I think she asked if you could repeat the question, Renee.
Oh, repeat the question. Okay. So there's been a lot of back and forth in the chat about SSRIs, about when to consider an SSRI, when how to initiate treatment, whether SSRIs are the best medication treatment for depression or anxiety, and what the contraindications are for considering starting an SSRI.
I'm going to apologize. I might actually take myself off video because I think I've got limited Wi-Fi right now. But in short, as I think I mentioned a little bit in the chat, really being clear on what is driving the presentation, and and thinking about, yes, anxiety and depression are worth treating, and that medication is one component of that, but also being really careful to understand, what else medically may be going on, and assessing for substance use, also assessing for family history. Anxiety and depression are certainly the most common, often, found together with many others. And for people, in these fields that we've been talking and hearing about, or persons with various developmental presentations, and it's important to understand what's driving it, and then is there depression or anxiety that's worth medication for. But when it's much more driven by something else, then to fix those things, or try to adjust those things.
Okay, thank you. We have a question for Dr. Tully and for Darcy and Camilla, which relate to whether any of the materials that you have developed could be incorporated into electronic health records, which many healthcare providers are now using.
I'm happy to start here. I see one of the comments in the chat of how you're sending recommendations might happen through an after visit note. What a brilliant suggestion. Thank you, Dr. Dooley. I would love to talk with you or whoever it is at your health system or organization that I could talk with to figure out the best way to design that. Just from a formatting perspective. It's a great idea, and would love to flesh it out. And I see Dr. Steinbuckle saying the same thing. And I think all of us, under the CalHope programs that have these services would really love to see both putting the resources in these after visit notes, but also, one of my kind of moonshot ideas is how do we also set it up so that you would be able to send a referral link for folks to install Soluna, or we have a sister program called Bright Life Kids that serves 0 to 12. So those are all brilliant ideas. Oh, thank you, Dr. Grady, for your copying and pasting of QR codes. So I think there's a few options, and I think we just need to talk to the right people at your system. So Dr. Dooley, if you're willing to shoot me an email or drop a contact into the chat for someone I can talk to, I will follow up. Thank you. I'm going to follow up right now, and we can maybe set some time together in the next week or so.
Wonderful. And Camilla and Darcy, did you have any other comments about that?
I can just say, I think with definitely, we can definitely look into that as well. A lot of times, even just going to the site, that is considered a key resource, and it's definitely, fun to play around and can kind of sort by asking questions and kind of the questions, whether you're a young person. But I will say, I do think often we've made, things like magnets and stickers and things that are just tactile. And so we'd love to kind of get those in the spaces too and have them readily accessible, because those are often helpful too, sometimes like the palm cards or things like that. But absolutely, we'll follow up and can help with formatting or getting the information in the right way to go with the various EHRs.
Thank you. And for all of you on the call, we can, any of you who in the post-call questionnaire indicate that you want us to provide you with material for your offices, we will work with Saluna and with Never a Bother to make sure that you can in the package that you get, that you will have those resources as well to distribute to your patients. So we will work with them on that. Could you put up the last slide or last slides, Sana?
Yes, let me do that.
So I want to thank everyone for participating in the this really wonderful uh, webinar. I think that we have all, even all, I think all of us, even the presenters, have learned things in the process of hearing these great presentations. So we really want to thank all of the presenters for their time and efforts. I want to remind everyone, if you would like to get a CME credits, please complete the post survey summit survey. And actually, we would really like it if everyone would complete the post summit survey, because we would like to look at what people how we've impacted your thinking about suicide prevention, and being able to give feedback to the American Academy of Pediatrics and the other supporters of this initiative. And I especially want to thank the organizing committee, Doctors Erica Berman, Danica O'Leary, Yolanda Ruiz, Sana Said, and Azrathi Patillo for all of your support and help. And if people have any comments or questions or additional things they would like to give us feedback about, please send them to Sana, our project director, project coordinator, who will get them to the appropriate person. So just to let you know that there are some upcoming events from the Chapter 1 of the Academy of Pediatrics. So we're having a chapter chat about California legislative advocacy for pediatricians on Thursday, April 10th by Zoom. And the Mental Health Committee, chaired by Lisa Levitt, Beth Grady, and Diane Dooley, will be having a meeting on Monday, April 21st. Both of these are on Zoom. And we have a events page and job posting, and we're very active on social media. So please keep in touch with us and give us your feedback so that we can meet the needs of you, your practice, and the community. And I want to wish everybody a great rest of your weekend. We appreciate your spending your Saturday morning with us and hope that it has been worthwhile. I know for me, it has been very worthwhile. So thank you all for coming. And we're able to adjourn a few minutes early. So thank you all very much and have a great weekend.